ഇത് ഇങ്ങനെ ഇരിക്കുക. Very good morning to all of you, and welcome to the day two of Rapid Revision course 2026. I am audible?
Yes, sir.
Okay, thank you. Moving on to our star speaker, Dr. Nitesh sir. Sorry for आपको इतने जल्दी उठा दिया. Nitesh sir, are you there?
Hi. नहीं Manoj, thank you so much. Yeah,
Good morning, sir.
thank you. Good morning.
So, should we start, sir? I
No
mean,
problems.
I will
Okay, sir.
introduce you, sir. Dr.
Yeah.
Nitesh is working as a professor in CDRI AIMS, New Delhi. Currently, Dr. Nitesh is pursuing doctoral research at Carolina Institute of Stockholm, Sweden. Dr. Nitesh has all, uh, Dr. Nitesh has almost published more than 202 papers in highly impactful journal and lecture around 186 as a guest lecturer in 24 countries. He has several international recipients of the several international and national awards. He has a fellowship in IIDT, IAPD, ADI, Royal College of Surgeon Physician, Glasgow, Japan Dental Association, and ICD. He is a board member and the communication officer of IIDT. He is the general secretary of ISDT. He is also an associate editor of Dental Traumatology, Brazilian Oral Research Journal. Sir, welcome. We welcome you on behalf of
Thank you.
ISPPD and PGIM here. Can we have
Thank you so much,
recording?
Manoj. Yeah, it's an honor to be speaking to the postgraduates in my own country, and certainly I will try my best. Yeah.
Thank you, sir. Thanks a lot, sir. Can we have sir's recording?
Hello, I'm Dr. Nitesh Tiwari, and I will be speaking today on dental trauma classifications and how we have evolved and how those classifications have been formed. Thank you so much, the organizers of PIDO or RaRe program, especially Dr. Manoj Jaiswal from PGI Chandigarh and Dr. Aditi, along with that, the head office of ISPPD. Thank you, Dr. Virendra Goyal sir, Dr. Sudhin Baliga sir. Thank you so much. So I'm Nitesh, and I have a keen interest in dental trauma, and I work as professor in All India Institute of Medical Sciences, New Delhi, and I work in Center for Dental Education and Research. And if you don't know, this is the best dental college in India, and it was ranked by an IRF in 2025 rankings. So I am presently in Sweden, and I'm working in Karolinska Institute, which I joined for my PhD in Department of Dental Medicine, and I'm working on combination injuries. And I came here in November 2025, and I was so honored again because this ranking came in this early spring, somewhere in 20, and it was ranked as globally number one. So I was joking to my colleagues that I actually am representing the best dental college in India and then the best dental college in world. So that's something about what I've been doing of late. There are three main organizations of dental trauma, which I proudly represent or request you to follow for the works which we have been doing. One of them is Indian Society of Dental Traumatology. It's an interdisciplinary organization which we formed in 2017, and right now we have close to 630 members. And this is a very good forum for you to learn the interdisciplinary care of dental trauma cases and the international counterpart of it. And largely we all know it because of the guidelines, the International Association of Dental Traumatology. I'm working as a communication officer there, and it's something which I have been following since my post graduation. So those of you who want to do more in dental trauma, so this is one of the forums. And the most purest of the organization is the Dental Trauma Guide, which is in this part of the world, in Scandinavia, in Copenhagen. And so this is the core of dental traumatology, and we will be talking more about it. So yes, I'm here to talk on dental trauma classifications and how the trauma classifications have evolved. This is an interesting part of traumatology and something which everybody has to know, because without this there is no diagnosis. Without this there is no treatment planning. If you do not know the classification, if you do not know how to communicate, it doesn't take you any step further. So in this 20-25 minutes presentation, I will be talking about the classification general concept. I'll be talking about evolution of how those classification system has happened. I will be talking about three main index, which will be something new for you, which is about the dental trauma severity index, the prognosis index, and the critical factors or errors which come in part into the core outcome sets. So why is dental trauma so important? Why is dental trauma so unique, or why is it so confusing when it comes to management? Number one, because it's an emergency. So we all know that if you have ever seen a case of tooth avulsion, luxation, maxillofacial injury, or an injury which has resulted in a major damage to the dentofacial region, you will understand the nature of emergency. And this is not just the case in India, because we see a lot of cases of delayed reporting, and we see the prognosis which is not very good. So those things are something which always bothers when it comes to dental trauma care or research. Second is the uniqueness. See, my entire life, when I started my post-graduation, it was way back in 2027 and 2007, sorry, and we are close to 20 years now, and since then, since that time, the cases which I have seen, they have largely been very unique. You won't find even two crown fractures which are identical, and that's one of the reasons why we cannot do randomized controlled trials in a lot of aspects of dental traumatology, and we end up with the evidence which is coming from cohort studies. And now when we look into those evidence while making guidelines, it's very difficult. And it becomes really difficult when people like you who are listening to this lecture or doing post graduation right now, when you become researchers, when you become faculty, you should understand these three factors when it comes to dental trauma research. So if you use the classification system properly, if you understand the traumatology, then things will be much easier for or much useful for the people who read your works. So this is known as dental trauma pentat. We gave this in one of the textbooks of pediatric dentistry 3-4 years ago, and this actually sums up any trauma question which you deal with in your MDS exam, because this is a rapid revision program. So I will be taking cues towards dental trauma exam questions as well. So in this, if you just remember, so it is very easy for you to write an answer, because you can take care of these five factors no matter which type of trauma it is. You will be taking care of mechanism of traumatic dental injuries, the predisposing factors, the demographic factors, the nature and intent of trauma, and the elements of traumatic episodes, which are the host factors, the resilience, the object shape, energy, and the direction of force. So this is something which you need to remember. So you can just use this anywhere, whether it's a long question, whether it is a short note. And why dental trauma got recognized, or dental traumatology got formed as a society, or is now blooming everywhere in the world, it's because of this person's work. This is Jens Andreasen, and he started as an oral maxillofacial surgeon, and you all know Pinborg. The Pinborg tumor was named after that person. Dr. Jens Andreasen was a student of him. And in late 1960s, when his first papers came, it was about cyst and tumor. Then he got an opportunity to work towards dental traumatology, and if you want to learn more, you should try to recognize his works and try to see, because it's an entire journey. So in the bottom you are seeing his works. So it's not Manhattan, not from New York, but from his works. And when you write your answers, it's always good to write about the history when you're writing the background. And one of the things which we did just to see how dental trauma was in the period before Jens Andreasen, we did this paper in 2022, and this is a scoping review when we wanted to see what were the things done in dental traumatology before the Second World War. And these are the few of the papers which are the earliest ones, just the six of them, and we could get the full prints of it. And just to reduce the conversation, or just to focus it, let's see when the first trauma classification came. So that's there. So it's 1936 when J.C. Brower gave the first dental trauma classification system, and Dr. John C. Brower became the first dean of University of North Carolina in USA. And this was interesting classification because it only dealt with the heart tissue injuries. The type 1, enamel fractures, like just without, if any, exposing the dentine. And then type 2, large part of dentine is exposed. Type 3, exposure of the pulp. And then type 4, the root fracture, which can be a middle cervical or the apical third. So there was no mention of any sort of displacement or any luxation injuries. So that's how it all began. And then came the Rabinovich classification, which is 1956. And so like 20 years, the world was in World War. And that classification was the first classification where actually, if you look at displaced teeth, so luxation injury came into picture only in this classification for the first time, 1956 Rabinovich classification. So largely, if you just look into these two initial classifications, you will see the thought process. So it was about the hardest tissues. They didn't even consider the soft tissue recording in that place, or it was not important. It was about tooth, like trauma to the tooth, and tooth meant root, tooth meant crown, and that's how anatomically they were trying to focus on those things. So then came the Ellis and Davy classification. It's very important historically. I don't like it, but I'm just expressing it because this classification has got its issues, and we will talk about it as we move further. And this classification is the first classification which any undergraduate learns in dentistry in India. And this classification was given in 1960. There are 9 classes, and you all know it by heart, I'm very sure. So first, second, and third, just to make it easier, it's about the crown fractures. And so first is about the enamel fracture. The second is fracture about considerable amount of dentine is involved. Third is about exposure of the pulp. So when you are dealing with this classification system and you are being asked a question on it, so if your examiner asks you that what is the ALS class 3, so then you cannot just say enamel dentine and pulp fracture as a postgraduate student. You are supposed to learn this definition. So when it comes to definitions and classification systems like this, you have to be a little careful because your examiners are looking at the keywords in the definition because they know it. So you need to be very careful when a question is as direct as classification of Ellis. So then these three are classifications for the crown fractures. The class 4 is the fracture of the tooth, which leads to like traumatized teeth, which becomes non-vital or with or without the loss of the crown structures. Then there is type 5, which is the result which is for the avulsion. Type 6 is for the root fractures. Type 7 is for displacement of the tooth, the luxation injuries. Type 8 is the fracture of the crown and mass and its replacement. And the fracture, class 9 is the injuries to the primary dentition. And that's why I don't like it. Because when you have a whole spectrum of traumatic injuries affecting primary, then you as postgraduates and we as faculty, we have seen that all our lives. So then why is enamel fracture of a primary tooth and tooth avulsion of a primary tooth is in the Ellis class 9? And that's the biggest problem. And that's why when we started working in dental traumatology, especially for IADT guideline, so we always just shied away from such classification systems. So by and large, if you look into any classification system in dentistry or in medicine, they are either the numeric classification systems, like these numbers and codes, and then second, they are descriptive classification systems, where we have tried to describe. The codes are important for two reasons. Number one, they are easy to, or they are like quick to communicate. So if you say LS class 2, many people who know LS class 2 will know it's an enamel and dentine fracture and it's universal. While if you and similarly, if you are trying to write a code in your data sheet, or you are trying to develop a computer program, and you are trying to fill in things, or especially these days when AI is involved, so codes are important. But when it comes to direct communication or clarity of communication after 30 years, so if I look back into your trauma files and you have written class 2, but when you examine the case, there may be 2 or 3 fractures involved. So then if you have written, documented everything in words, after 30 years, it will be easier. So it's a catch-22 situation, like you have plus and minus of both type of systems. So that's Ellis and Davy classification. So as we move further in the different types, so there is Garcia-Godoy classification system, and there is McDonald's modification of Ellis and Davy classification. And then there is Ulfon's classification system. So these are all like progressive classification systems. So Garcia-Godoy is important because Garcia-Godoy was primarily for the primary teeth. So if somebody asks you a classification system for primary teeth, that's the one. So 1981, so 83 and 85. By that time, things were moving towards different types of people having different types, different ideas. This is the first classification system where somebody thought of that injuries are not solitary, which we are now resurfacing, or we are now revisiting in a way, because a lot of classifications which you will be seeing, and we will talk about it in some time, they are just like one injury at a time. Here, Pulver's classification is a classification on combination trauma. So you have class 1, where you have 4 divisions, class 2, 2 divisions, and class 3. So like let's take class 3. Class 3 div 1 is fracture with exposure of the pulp and no displacement. And class 3 where division 2, when there is exposure of the pulp and displacement. So you can compare this with Ellis classification. So Ellis class 3 and Pulver's class 3, it's almost the same, except for the fact that there are 2 subdivisions depending on whether the displacement was involved or not. So if this classification system was followed, maybe the trauma guideline would have been different. So let's see. Let's move further and let's see what other classification systems exist in the world. So we have the WHO classification system. I used to be really scared of this classification system even as undergrad and postgrad because of those codes. So WHO and ICD, they have their own codes. So when you have 873.60, and I'm sure that you will have some questions on it. So those codes represent the tissues. So when you have 873, it represents a system. Then 60, six represents another system, like maybe representing a tissue, which is a tooth. Then 0, 1, 2, 3, 4 will be the codes. Similarly, if you go to the bottom part, so it is the ICDA system, which is about the fractures of the bone and dislocation, which is there. So you have these slides, and I will be sending over these slides for you for your preparations as well, so you can use it. So let's talk about the classification system, which is the most recognized one in dental trauma clinical care, and the IADT guidelines, and even in dental trauma research, which is Andreassen's classification, the same person on the whose picture I showed you before. So it is by far the most descriptive one, because it describes the injuries into injuries of the hard dental tissues. The first is the enamel fracture, then enamel fracture, which is uncomplicated crown fracture, enamel dentine fracture, which is again an uncomplicated crown fracture. So in Andreassen's classification, there is a cube. So if you have a complicated term attached, that means there is exposure of the pulp. So if you have uncomplicated crown fracture, it can be enamel fracture, it can be enamel dentine fracture. And if it's a complicated crown fracture, that means there is a pulp exposure. And mind you that if your examiner asks about the correct definition, so then you need to be little careful about the keywords in this slide. So you have uncomplicated crown fractures, complicated crown fractures, then uncomplicated crown root fractures, complicated crown root fractures, and root fractures. So this is about the hard dental tissues. Then Andreassen classification also has injuries to the periodontal tissues. which is very important, especially when it comes to trauma management and emergency care and later the prognosis. So we have concussion, subluxation, extrusive luxation, lateral luxation, intrusive luxation, and avulsion. You all know this. There is nothing which is difficult here. So you can easily remember. So that when there is no displacement and there is injury and pain, and there is no bleeding, so like there is no mobility, there is no displacement, and just the patient is complaining of pain, and so the injury will be contusion. That's the simplest of all luxation injuries. That there is an impact, there is compression of periodontal ligament, but then there is no mobility. So the moment there is mobility but no displacement, that is subluxation. So in subluxation cases, you will find a classical, if patient is reporting to you early, you will see a classical mobility and there is gingival bleeding, which is right at the marginal gingiva. So then there are two injuries, which is intrusive luxation and extrusive luxation, like axial injuries. Then there is lateral luxation when the tooth moves out, but tooth is still in the socket, but the root is moving out or the root is moving inside. That's lateral luxation. And then there is avulsion. So it's quite easy. It's not something which you cannot easily remember or you can write about. And these things are quite descriptive in terms of you explaining them. Then comes the soft tissue injuries, which are the injuries to the gingiva or the oral mucosa. These includes the contusion, the abrasion, and the laceration. So laceration is not there in this slide, but then laceration is also there where there is a discontinuity of the mucosa, and that has to be managed. Then there are injuries to the supporting tissues in Anderson's classification, which is about the injury to the socket wall, the fractures of the socket wall, and maxilla and the mandible when they are involved. So the most recent classification system is the ICD-11 classification system. And I have a QR code where you can download all the articles which I have been talking about. And this classification system is what you can write when it comes to recent advances in trauma classification system or traumatology, because it was a big movement for dental traumatology when ICD accepted these codes. It was never ever happened. It had never happened. So it took close to 3 to 4 years for a group which is mentioned here, including Dr. Jens and Yashan, to push it into ICD system. The system is similar to what you saw in WHO classification system. So there is a block name. It's easy. So like when you have a block name, first group block name. So block name means the different injuries, and then there are injuries with the codes. So you just need to remember that if you see the codes, NA0D remains same. What is different? The things which are after zero. So injuries to the hard dental tissue and pulp are all starting with zero. So like NA0D dot zero, and then 0, 1, 2, 3, and then you have unspecified and others. While the periodontal tissue injuries, they have a different codes. So they start with 1. So NA0D dot 1, and then 1, 2, 3, 4, and so on. So it's something which you need to remember because it may be there in your pedagogy exam questions, or it may be asked by your examiners. Another thing which has come up in after 2019 and 20, it's Eden Basal Dental Trauma Index. So Eden Basal Dental Trauma Index is a sort of severity index where there are 5 different digits, and then there is a digit for the tooth number. So these digits, as you can see on the screen, the first is about the tooth nomenclature, the tooth code and the FDI. Then there is crown, about the crown fracture, the root fracture, the luxation injury, root maturity, and the bone. So if I take you further, these are the different codes. So what you need to do, if you see the injury, you need to write the tooth number in terms of FDI. Then you need to see the crown. So if you have the crown, you need to have a code for it. I will show you one of the practical examples. So like you can have enamel fracture as 1, 2, and so on. It's something which is there in the article which you can refer to when you are using this. Then you have a root. You can code it from 0 to 3. You have luxation injury. You need to code by the capital letter capital alphabet. And then root maturity as I, M, and R. I is immature, M is mature, and R is resolved, which definitely will be related to primary tooth trauma. The fifth code is about the bone. So you can have a plus if there is an alveolar process fracture, minus if there is no fracture. So how do you use it? So first you can have the FDI system. You just mark it. So if a central incisor you on the right side you can have 1 1 or 2 1. Then the second is about the tooth crown fracture. So crown fracture you have these codes as you can see in this picture. So you can have 0 to 5. Then the root fracture, depending on which level it is, 0 to 3, 1 to 3, 0 to 3. Then you have luxation injuries like none, concussion, subluxation, just a first letter capital. Then you have maturity status, easy, so you can do that. Then the alveolar process fracture, depending on whether it is present or absent, plus and minus. And this is how it is represented. I'll show you an example. Uh, Before that, there is soft tissue injury. So till 2020-21, when hidden basal index was first formed, so there was only component of the hard tissues, periodontal tissues, and the bone. So then there was a modification about addition of soft tissue injuries. So these are the soft tissue codes which can be added. So this is the other paper which was done in 2021. And those of you who can access, but I won't be able to take it further. This is a screen. You can take a screenshot and you can use this because this is about hidden basal trauma calculator. So you can use this and you can use this case as a representative case. So here you can see that the tooth crown is intact. There is no bleeding. I can see there is some movement which has happened, which is probably intrusion. I can see that the root apex is immature. So how I use that code? So first you can see that this is the code here. So you have 2 1, which is the tooth number. Then 0 means that there is no crown fracture. 0 means that there is no root fracture. Then this is inclusive luxation, the capital I, small I for immature root, and there is no bone fracture, so minus. So this is how we do the grading, and when you use that trauma calculator, it will be very easy. So since there was no soft tissue right now in this case, which we were able to see, so we just gave a superscript code of 0. So this has been widely accepted, and a lot of trauma organizations actually use it these days. The Sports Dentistry and Dental Trauma Guide, especially, and this is very useful in combination injuries, which currently I'm working on. And this is how things will be moving in next 5 to 10 years in dental traumatology. So quickly, just to save time, I will just show a couple of slides for dental trauma outcome index, which has come. So those of you who don't follow dental traumatology journal, this came in 2025, and you can download it from the QR code, which I'll be sharing in the end. And this article is about trauma outcome. So it follows almost the same system as Eden Basal system does, but it is for the cases where you are following it up. So you have recorded the trauma, it's fine if it's a fresh trauma. Then what about prognosis? So then there are factors about crown restoration. It has a code for root fracture healing. It has a code for external root resorption, root development, and there is about other adverse consequences. So this code is actually what has been proposed for trauma registries. So you have things in computer where you can just fill in the codes, and so after 10 years from now, if you have those codes and you have follow-ups, so then dental trauma research or the people who look into those records, they will be able to get a lot of information which will be useful for people across the world. So this is an example. So it's like 3 years, 7 months follow-up, 5 years, 2 months follow-up, 5 years, 10 months follow-up. So if you have the codes and you can use them, so you can use those codes and you can have the entire thing written in form of a small code which can be used by AI, which can be used by people in future. So last thing which I want to talk about is the core outcome sets, which were given by Kate Kenny, and 2017 this paper came, and then there is a minimum outcome sets which also came in some time. So in this core outcome set paper, it talks about three things. Number one, what are the most essential outcomes for all injuries? Number two, what are the injury specific outcomes? And number three, when those outcomes are to be recorded. So this is again a pedagogy question for you. Many times people ask this question because this is important for you to understand. Because if you do not know, so and core outcome sets is not just dental traumatology. The core outcome sets have been proposed for almost all specialties across medicine. So dental traumatology core outcome sets involves three things. Like I said, I will repeat that. The what are the things which are generic, the things which are specific, and the time points when they are taken. So as I end, just a couple of slides on what do you expect in your examinations. So dental trauma questions have evolved like traumatology. So you have questions on theory, which is about the essay questions and long questions and short questions, which where dental trauma classifications are important. Your case presentations, your pedagogy, and the grand viva. So there is nothing where you can say that it's not going to come. So dental trauma questions come, and there are a lot of advancements which you need to focus. But right now you should focus on yourself, because you are now going to be pediatric dentist very soon, and I wish you best, because I know that you have worked hard for 3 years, and just overcome all the anxiety which you have, and just give your best shot in your exams. Best of luck for this. And this is my department in New Delhi, India. I really miss them. And I'm here saying thank you to all for listening to this lecture. Thank you so much.
Thank you, sir. Thanks a lot. Your lecture was insightful as well as inspiring also, sir. Thank you for doing a revision of such a complex topic of dental traumatology effortlessly for our postgraduate student. Thank you, sir. Can we have a certificate? So please accept the appreciation certificate from the ISPPD office.
Thank you.
Thank you, sir. Thank you, sir. Moving on to next speaker, can we have the CV for next speaker, Dr. Hitesh Mittal? Yeah. Moving on to next speaker, Dr. Hitesh Chandra Mittal. He is an alumni of PGIMER Chandigarh and working as an associate professor and in charge in the Department of Periodontics, ESIC Dental College and Hospital, Gulbarga, Karnataka. He is a fellowship. He is a fellowship fellow. He has a fellow holds the fellowship of International Association of Dental Traumatology, fellowship of International College of Dentists, fellowship of International Association of Pediatric Dentistry, fellowship in Forensic Odontology, and has a teaching experience of more than 13 years and recipients of the several awards, among which the Best Scientific Award in 2025, 24, and 22. His contribution includes more than 28 research peer-reviewed publications and more than 500 citations with H-index of 12. His career reflects blends of scientific excellence, innovative research, academic leadership, and the social commitment to advance pediatric oral health and dental trauma care. Over to you, Dr. Hitesh.
Thank you, Dr. Manoj, and very good morning to one and all. I will be discussing trauma management with some clinical scenarios so that postgraduates can remember it and they can recall and they can correlate the clinical theory and the outcome and management, and they can properly write their exam. So best wishes to the postgraduates, and thank you to the organizing team from PGI Chandigarh and ISPPD head office. Over to Dr. Manoj for starting the recorded video.
Thank you. Thank you, sir.
Morning, all from ESIC Dental College, Kalburgi. First of all, I would like to convey my sincere gratitude to the organizing team, my own teachers, respected teachers, Dr. Ashima, Kaditi, and my dear colleague, Dr. Manoj, and the dignitaries from ISPPD head office for giving me this opportunity. Today, I will be talking about crown and crown root fractures and their management, which constitutes majority of the traumatic dental injuries, that is 26 to 76%, and two-thirds of the traumatic injuries occur in the children. These crown and crown root fractures are most of the time asymptomatic, and patients do not seek immediate treatment because they are asymptomatic, there are no symptoms. And here you can see patient reported after 2 years for the aesthetic region, and you can see there is a significant gap between the fragments, and there is exceptionally rare finding, that is deposition of dystrophic dentine along the fracture line. Crown and crown root fractures can be classified further into complicated fractures or uncomplicated fractures depending upon involvement of the pulp. Now, moving on to the definitive treatment, we have to evaluate the relevant history, when, where, and how of the dental trauma, and it needs to be documented as well. The relevant medical history need to be taken because patient might be affected with bleeding disorders, orthogonopathies, any drug allergy, may present with some liver clot, and here you can see how the patient is having active bleed from the bandage and pressure packing is not working and needs some systemic intervention. Documentation is also an important aspect, not just for the treatment but also for the medical legal purpose. Standard charts are required to be documented for extraoral and intraoral findings, including pulse sensibility testing and standard radiography examinations. And any immediate treatment given for pain relief or maybe TT injection need to be documented. Photographic documentation always adds to the clinical evaluation and has been recommended by IADT 2020 guidelines as well. Now moving on to the soft tissue examination, need to be palpated for any foreign bodies or tooth fragments which may be embedded into the soft tissue wounds at the time of injury. IADT 2020, as per guidelines, the fragments in case of crown fractures must be accounted for, and if could not be traced, we need to evaluate to soft tissue radiographs by reducing the exposure to 1/4 of the normal. And these foreign bodies may be radiolucent, and it is very important to that we need to clean the wounds and irrigate with copious saline and palpate them for any kind of foreign bodies and before any kind of suturing. Hard tissue evaluation need to be done for each tooth and for the extent of the fracture, any mobility present, any change in the color of the crown, any change in the color of the pulp, no visible tooth in dentine, or any abscess or fistula present, and percussion tone and sensitivity, any tooth which is displaced from the socket, and evaluation of the occlusion, especially when patient is presenting late and the antagonistic teeth have moved into the space of the fractured crown fragment, presenting restorative challenge. Another thing we need to evaluate is alveolar fractures if they are present. Next, coming to the radiographic evaluation, which is important to see whether roots are, how is the root maturity status, any associated root fractures are present, or any resorptions along the root fracture, along the root surface, any displacement of the root from the sockets, and periapical radiolucencies or any other changes, because they may indicate previous trauma. These radiographs serve as a record for comparison at later visits as well. Now coming to the definitive management of these crown fractures, first comes the enamel infections. These are very common and often overlooked. These are incomplete fractures of the enamel within the lying within the enamel and usually arrest at the D's because of the change in elastic modulus known as crack arrest phenomena. The pattern of these crack lines usually follows enamel roads directions but may vary depending on the location of the direct impact. Next comes the follow-up and the diagnosis part of the crown infections. These crack lines becomes easily, obviously visible by reflecting the light off the tooth surface or by using transillumination. No follow-up is required. These have pulp survival chances similar to the normal teeth, but when there is associated ligation injuries present, the pulp prognosis decreases and chances of necrosis increased up to 34.5% because the bacteria may ingress through the crack lines when blood supply is compromised due to ligation injury, and it is recommended to seal these crack lines with unfilled resins to protect the bacterial ingress. Now, next type of fractures is enamel fractures, which are the major type of crown fractures, that is 82%, and these are diagnosed clinically where there is no involvement of the dentine, and one periapical radiograph is recommended for future reference. The treatment options include simple recontouring of the sharp edges, or when distal fragment is there, we can just reshape the crown. Other cases, if fragment is available, we can do fragment reattachment with very good success rates, and composite restoration is another definitive treatment provided. As per IADT guidelines 2020, the follow-up required is at 6 to 8 weeks for these type of injuries, and then followed up at 1 year. Next type of injuries is enamel and dentine fractures, which are 33% of all crown fractures and more common compared to the complicated fractures. These are also diagnosed with the visible examination, but may present with some sensitivity to temperature variations. These are no tenderness on percussion, normal mobility, and pulp sensitivity test may be positive. One reference radiograph is always recommended to evaluate the root status. We should always look for the minute pulp exposure because there may be plaque accumulation at the fracture site because of the sensitivity to the toothbrushing or thermal changes, and we might miss out on the pinpoint or minute pulp exposure. The treatment options for these types of enamel and dentine fractures include a temporary treatment like dentine dressing with glass ionomer cement, and definitive treatments like fragment reattachment and composite restorations similar to the previous. The dentine dressing is a temporary or emergency treatment for the time being, provided for definitive restorations, till definitive restorations are given. This will prevent dentine sensitivity because of the fluid movement and may prevent the ingress of bacteria through the porous dentine. And Raven et al. Reported that the pulp survival is there will be pulp necrosis in 54% of the cases when no treatment is provided, compared to 8% when dentine coverage is being given. Similar reports has been reported by McGuire et al. In 2000 for mature as well as immature teeth. When left untreated, you can see here the tooth turned non-vital on a period of 3 months because of the exposed dental tubules, which act as pathway or portal of entry for bacteria, overcoming pulp defense. Depending upon longer the exposure, more higher chances of pulp necrosis, and more closer to the pulp the fracture is, there are more chances of the fracture. Here we treated this one with root canal treatment followed by composite buildup. Another definitive treatment comes the composite restorations, which is very conservative treatment options, and a single visit can be performed with reasonable durability, and we can easily repair these restorations, and these provide natural appearance by either using multi-shade layering technique or monochromatic composite with cut-back techniques. And the success rate of the composite restorations is very good, like Postgraduate et al. Reported more than 90% at 4 years. Either they are using monochromatic or polychromatic composites. Similarly, D'Souza et al. Reported 90% success rate after 10 years, while Demerco et al. In 2015 they reported above 80% of the success rate over a period of 3 to 5 years. Now comes the another definitive treatment modalities for enamel and dentine fractures. This treatment option is fragment reattachment, which is preferable because it restores the original contour, color, texture, shape, and alignment of the tooth. Here we see clinically and radiographically how the tooth is, the fragment for fracture is imperceptible. This is also offers time and cost effectiveness and psychological benefit by providing immediate outcome and have a positive impact on the quality of life of the child. Now coming to the survival of these fragments, you can see that Anderson et al. In 1995 reported half of the reattached fragments got debonded in 2.5 years, while the recent literature by Bissinger 2021 reported more than 84% survival for adhesive reattachments after 2 years. Here you can see one case where two teeth were fractured and we can trace back only one fragment. So we did one fragment reattachment and another tooth we did composite buildup. And here you can see excellent results over a period of 1.5 years. No difference in the aesthetics or the outcome for pulp. In order to have better predictability of the fragment, different bonding modifications of the fragment has been tried in the literature. The basic one is the simple reattachment where no preparation of the fragment, so tooth is performed, just acid etching, bonding, and an intermediate adhesive was used for the reattachment. Next comes the pre-bonding modifications where some preparations were performed in order to increase the surface area by using bevels, external bevels or internal bevels and dentinal grooves. But these kind of modifications led to compromise in the precision of the fit of the fragment and thus are not preferred in the literature. So now coming to the post-bonding reinforcements, these do not affect the precision fit and reinforces the reattachment alongside. So this can be performed by external chamfer or double chamfer over contouring or vertical grooving once the simple reattachment has been done. Rice et al. Reported that post-bonding over contouring provided better reinforcement in terms of fracture resistance. Similarly, the latest article published in 2026 by AIMS, New Delhi, by Kidwai et al., and their findings are post-bonding reinforcements are much better compared to the simple reattachment. And among the post-bonding, you can see the over contouring is better than external chamfer. Next comes our intermediate adhesive materials. These various materials have been tried across literature. You can see Junjunwala reported nanohybrid and microhybrid components having similar results, but these are better than light core, glass iron or cements, although various materials can be used. What is the key for the fragment reattachment is intimate adaptation of the fragment and curved bonding systems are predictable. Here in this case, we had used double chamfer post-bonding reinforcement, which help in adequate retentivity as well as aesthetics. However, we can see whitened appearance, which shows desiccation prior to the bonding of the fragment. These desiccated fragments have decreased bonding strength because of the inability of the resin tags to penetrate through the dry dentine. So hydration of the fragment has been recommended. Shirane et al. Advised for 24 hours immersion in distilled water, while Pobel et al. 2017 reported there is no difference when the fragments are immersed more than 15 minutes. IADT 2020 guidelines recommended for immersion in saline or water for 20 minutes. This improves the aesthetics as well as bonding strength. Now the broader questions still remain, being a postgraduate, for critical evaluation of literature, whether we should be doing reattachment or restoration or which one is providing better results. Now you can see the latest article by Soner et al. 2025, which who reported that preheated composites were used for reattachments to provide better fracture resistance compared to direct composite restorations. Similar results by Madhubala et al. From AIMS New Delhi, fragment reattachments after rehydration provided better results compared to direct composites. And this study also reported humidification chamber instead of immersion rehydration of the fragments. However, there are some contrasting findings also available in the literature. You can see Hawk et al. Reported that direct composites are better and reattachments only have survival for 52% at 2 years. Then some meta-analysis, by Dr. Nitesh Tiwari in 2024 in Evidence-Based Dentistry, where he reported that the relative risk was 2.2 for uncomplicated fractures and 2.5 for complicated fractures in favor of the fragment reattachment. Then comes another dilemma of whether we should be doing in-depth pulp capping when dentin is exposed. The literature is clear on that. There is no need for in-depth pulp capping unless there is remaining dentin is less than 0.5 millimeter. Even animal studies have reported that there is no harm to the pulp when remaining dentin thickness is 0.2 millimeter. Here we have done no pulp capping or in-depth pulp capping for the attachment, and you can see over 1 year there is no adverse events. Also, when there's deeply extended fractures of the enamel and dentine, either in medial side or distal side, closer to the pulp bone, IADT has recommended that when pulp is visible, we should be good going in that pulp capping with calcium hydroxide. Although its use is disputed because of the poor adhesion of the calcium hydroxide liner to the dentine, and it might get pulled away during pouring of the compost resins. And it's been reported that there is physical and chemical degradation of the calcium hydroxide liner, leading to bacterial penetration. And even more important is the good hybrid layer, which reduces that formation because we are compromising on the seal because less surface area is available for that. Next, what we should be doing if we are doing partial pulpotomy in this case, we can see we can adequately seal with the medicament, and medicament will be in place, kept in place, and we can see excellent results. Even if we see the literature, Chang et al. Recent literature 2024 reported pulpotomy is significantly better compared to the that pulp tapping for uncomplicated crown fractures. Next case comes the case of crown dentine fracture, enamel dentine fractures, and here we can see some pink hue is also visible, little darkened appearance, and patient is having a history of spontaneous pain and immature. So we wanted to see whether we can do some kind of maturogenesis through pulpotomy in this case, and when we saw that the pulp was found to be non-coherent degenerative pulp, and it comes out as a single piece. And such case reports has been reported that when the associated luxation injuries are present, so they become necrotic within 7 days. This patient reported after 8 days of dental. So we should not just focus on the hue and just jumping on to the uh, fragmentary attachment or any kind of dentine dressing. Our prognosis may be dependent on the luxation injuries. Where here you can see Robertson et al. In 2000 and Wang et al. 2014. They evaluated the effect of luxation injuries, and you can see if the necrosis likelihood increased from 0% to 28% when associated luxation injuries are present, uncomplicated crown fractures. Similarly, the Wang et al. Reported that the mature teeth have higher odds of ratio for pulp necrosis when luxation injuries are present, and when different types of luxation injury also they calculated odds ratio. The community survival was 72% pulp necrosis at 12 months when there is associated luxation injuries are present. How luxation injuries increases the risk of necrosis and pulp prognosis is comparatively poor. But here I would like to show you a case where extrusive luxation is present in addition to the crown fracture, that is enamel and dentine fracture, and we can see conservative treatment was performed, and patient is doing fine at 12 months without any adverse event. So do not jump onto the therapy just by looking at that luxation injury is present. We should be conservative in all the time. Enamel dentine and pulp fracture, next category of the crown fractures, which are present 5 to 8% and can be diagnosed with the presence of slight hemorrhage, proliferation of the pulp when patient is reporting with delay. Usually there is no spontaneous pain and some sensitivity is present. I always record one radiograph for reference and pulse sensitivity testing as well. In this case, they need more to get follow-up as recommended by IADT 2020 guidelines at 6 to 8 weeks, 3 months, 6 months, and at 1 year. If we see at the treatment options for these complicated crown fractures, the options include that pulp capping, Swiss pulpotomy, cervical pulpotomy, deeper level of pulpotomy, or apexification or root canal treatment, depending upon the varied clinical scenario like size of the exposure, pinpoint exposure, large pulp exposure, and the delay whether patient reported within 24 hours or days or months. And there may be some change in the color, hue of the pulp, or there may be discoloration of the crown or abscesses present. Historically, we had seen there is some flow chart for this for management of these complicated crown fractures. Like when patient is reported within 24 hours with pinpoint exposure, we can proceed with that pulp capping. While if the exposure is large but patient reported within 24 hours, we can do partial pulpotomy. And if patient reported after 24 hours, we should do partial pulpotomy or deep pulpotomies. But if patient reported after 72 hours, we should do for the pulpectomy. But this does not hold true now. And IADT 2020 guideline are silent on this aspect and has not mentioned about impact of pulp exposure size or treatment delay and how to choose the vital pulp therapy for these cases. The emerging concept is not just the size of the exposure or the delay in the treatment, but what is the critical is where the inflammation is extended and where the pulp healthy tissue we can find which level it is and what level of amputation you can see the healthy pulp. So the size of the exposure or the delay might dictate the amount of tissue removal required, but the clinical assessment is very important. Like we are able to achieve the pulpal hemorrhage control, and visual inspection shows that pulp is coherent, vital, and healthy tissue, and not degenerative tissue. So next comes the SWEX pulpotomy. It can be performed by removing 2 to 3 millimeter of the pulp tissue and placement of the medicament, because the studies by SWEX and Fuchs et al. Shows that the inflammation is confined to the corner 2 to 3 millimeter even after several days, 7 to 10 days, with the excellent success rate of 94 to 100%. Next comes if we could not achieve the hemostasis in the removal of the 2 or 3 millimeter, we should proceed with the me. And if you can pinpoint exposure, patient reported after 24 hours, maybe 2 days after the trauma. And you can see when we started opening up the canal, we can see there is bleeding is present. Applied rubber dam immediately, and we can see that after removal of 2 to 3 millimeter of the further pulp tissue, or we did tonal pulpotomy, and we can see the healthy pulp here, and medicament was applied with the successful procedure was performed. Similarly, if we could not achieve at this level, the processes cannot be achieved at this level, tissue can be removed from the radicular tissues, and here you can see how the radicular coronaradicular pulpotomy is being performed in the for maturogenesis of the teeth in children. If we look at the success rate of the this type of vital pulp therapy in traumatic injuries, we can see that we can see that the vital pulp therapy scoping review has been performed by Sharma et al. And we can see that partial pulpotomies have achieved higher success rate compared to the dark pulp capping, and there is no difference for the material when either we are using bioceramic materials or we are using any kind of calcium hydroxide. Further, if we look for the literature by Donnelly et al. And Alvar-Pillay and Madhumita, all studies conducted in 2022, and these also reported that pulpotomies are better than pulp capping, and partial pulpotomies are even better compared to the complete pulpotomies. Now here I would like to show you one case where crown fracture with pulp exposure is present and no cementum was involved. We can see The fragment was removed, and we can appreciate the large pulp exposure. And here, fragment reattachment was performed after doing the pulpotomy. You can see the precision fit of the fragment, and at the 6 months, we can appreciate the formation of dentine breach, indicating the success of the treatment. Now, next category comes the crown and crown root fracture. This comprises 5% of the traumatic dental injuries, and these are maybe uncomplicated or complicated, being diagnosed based on the clinical evaluation or visual examination. The fragments may be attached with the periodontal ligament and kept in position, may be slightly displaced. These may be tended to percussion, and pulse sensibility need to be recorded for reference. The radiographic examination might not show the apical aspect of the fracture line, and only the corner fracture line is visible here. Additional two radiographs are recommended, and additional one occlusal radiograph is recommended as per IADT guidelines compared to the other type of crown and crown root fractures. CBCT may be required if you feel that there is some additional information required for the management. The management or treatment is challenging in these cases because of the restorative and periodontal issues of intra-alveolar cervical fracture line, invasion of the biological width, and issues with adequate isolation with for a predictable reattachment, and most of the time multidisciplinary treatment planning is required in these cases. Now, if you look at the pulp therapy or endodontic management for these cases, it is similar to the crown fractures as I had discussed earlier. And if you look at the subgingival extension, and if it can be brought to supragingival, we can easily do the reattachments for composite buildups and crown as we restored with the other crown fractures. So, procedure required for bringing this fracture line to supragingival level are orthodontic extrusion or surgical crown lengthening with osteotomy or surgical extrusion with or without 180-degree rotation. And in hopeless cases, we can do extraction, and if available of the donor tooth, we can do the auto transplantation. More frequent and longer follow-up is required in these cases. Here, I would like to share one case of crown root fracture where patient reported with crown root fracture. Here you can see fragment is already lost, and gingival polyp fracture. We can perform this case, find pulp, healthy pulp, and we did MTA placement, and we can see excellent results over a period of 1 year. No issues in the outcome. Another case we did crown root fractures. Here you can see slight displacement of the fragment, but the fragment is held in place. Reported after 4 months, and you can see pulp proliferation into the in between the fractured fragments. Here you can see the fragment was removed and pulpotomy was performed, and the fragment was reattached followed by post-bonding reinforcement with over contouring. And here you can see over the 10 days only, we can see the dentine bridge formation is visible, indicating success of the treatment. Here we required longer required reticular pulpotomy. You can see the time delay will not be deciding factor, but achievement of the hemostasis and the healthy pulp will decide the level of the pulpotomy. Another case where patient reported after 2 years of mental trauma and no history of swelling or discharge. Here we will remove the fragment and perform root canal treatment followed by reattachment of the fragment, and you can see 1 month follow there is excellent healing and fragment in place. Another study, if you look at the literature, the fragment reattachments are viable treatment option for crown root fractures as reported by Khandelwal et al. In 2021. Another case where we did orthodontic extrusion. Here you can see patient reported after 5 days of trauma, and we did pulp therapy with short composite post and reattachment. And patient reported after 1 year again with the fracture, and patient is wanted some definitive treatment like orthodontic extrusion. In this case, the technique given by Hecker say rapid extrusion was used by placement of hooks and some keychain activation was done to extrusion for extruding the teeth, and you can see 4 to 5 millimeter of teeth are extruded with. And here in this technique, gingiva extrude comes along with the tooth extrusion, and we need to perform gingivoplasty, but and as well as we also need to perform retention phase, but patient is not willing and got better with the treatment. Just we replace strip crowns in this case, and over a period of 3 months, we can see that relapse happened in the central incisor by 1 millimeter, although
I think there is some network issue. Am I audible? Dr. Hitesh, please unmute.
Yeah, you are audible, Dr. Manoj.
Sir, I think there is some network issues, or it is recording is over. I mean,
No, I think there is some few slides more.
okay, just a minute. I will confirm with the technical team and we'll get back to you.
Okay.
Can you please tell me, is it from this slide?
Do you want sir to explain that? I mean, Dr. Hitesh can explain onwards if
Is it from this slide or
yeah, this is from you can start playing.
Okay, sir.
comes along with the tooth extrusion, and we need to perform gingivoplasty, but and as well as we also need to perform retention phase, but patient is not willing and got better with the treatment. Just we replace strip crowns in this case, and over a period of 3 months, we can see that relapse happened in the central incisor by 1 millimeter, although the gingival tissues are healthy palatally, but there is some festooning present in the labial side, maybe due to the composite uh, and need to be recontoured. Is surgical extrusion of the apical fragment in these type of crown root fractures. These are very rapid methods, and Kamenberg 1996 reported excellent results. All teeth survive, and we can perform 180-degree rotation as well when palatal fracture is the fracture lines inclined palatally, so that less extrusion is required. In hopeless teens, we can do submergence to measure the angular bone in growing children, and if that is not the case, we can do the extraction. Here is the comparative table given in the Anderson book, latest edition. Here you can see fragment removal is a good option when aesthetics not an issue, like palatal extensions are there, we can perform it. But also the extrusions are good options and they are time consuming, but can be performed in vital and non-vital fields. However, the surgical extrusion, they have the risk, they are rapid, but they have the risk of wound resorption as well as root canal treatment is required in these cases. So they are not good for immature teeth. In summary, I would like to see that any kind of crown and crown of picture, we need to talk about definition, prevalence, the diagnosis of clinical radiographic findings, recommended radiographs, pulse sensibility tests, results, and comparative treatment options, restorative in terms of restoration, health management. Every effort should be made to preserve the vitality, especially for the mature teeth. There is no effect of the time lapse or size of the exposure. We should quote studies for that, and we should write about pulse prognosis and how it's affected with the blood vessel injuries. So thank you for here. I'm ending with the quote: "Restoring a smile requires technical precision, while restoring confidence requires compassion." Thank you very much for your kind attention.
Thank you, Dr. Hitesh, for the excellent compilation of theoretical knowledge with the practical application. There are a lot, I can see there are a lot of questions being asked to you. Some of them you have answered, but there are a few more are there. Kindly, can we take this question?
Yeah,
Please
sure,
unmute
Dr.
yourself.
Manoj, we can, you, so you can
Is it
repeat
okay
some
to
of the question?
reattach after 2 months? Yeah, I will. It is okay to reattach after 2 months of trauma causing crown root fracture?
Yeah, sure. Because I had showed you two, three cases. There, one case we had done reattachment after four months, and another case after 2 years where dystrophic dentine formation was there. So we did that case after 2 years. So it is about whether fragment is there held by PDL ligaments and how the pulp is. You can always do the reattachment, and if fragment is inside mouth, there is no problem with the hydration. If fragment is outside, you can always do the hydration procedure. We need to evaluate the how the fragment is, whether it's been dried with lots of craze lines or it's in good condition. We can proceed with the reattachment.
Dr. Sakshi has asked, surgical extrusion, do we need to splint the tooth? And if yes, what is the material to be used for splinting and how many days?
Yeah, actually, it's splints for any kind of surgical extrusion. We don't need any after like splint. Okay, so when we did this surgical extrusion, we definitely need to splinting. We need to perform. It is just similar to like we are doing for our teeth. Similar like splinting need to be performed for 10 to 14 days.
Thank you, sir. There are a lot of questions. You can answer them separately. Can we have certificate? I mean, because we are running short of time, can we have certificate? Dr. Hitesh certificate. I think there is some technical issue.
No problem, Dr. Manoj. Thanks a
Minute, sir.
lot.
Just a minute, sir. It's in the next slide. The ISPPD technical team is handling that.
Okay. Meanwhile, we can take one more question, sir.
Okay.
Sir, is the screen visible now?
No. Thank you. Dr. Hitesh, please accept this is the appreciation certificate from ISPPD.
Thank you, sir. Thank you for inviting me. Thank you, ISPPD head office and Peace team, team PGI and Dr. Manoj, Dr. Pavitra, Aditi ma'am, Ashima ma'am. Thanks a lot for.
Thank you, sir. Thanks a lot. Moving on to the next speaker, we have Dr. Kavita over here. Dr. Kavita, please unmute yourself so that I can introduce.
I'm here.
Uh, hello, good morning, ma'am.
Good morning.
So, a little bit of about Dr. Kavita. Dr. Kavita is a dedicated pediatric dentist, has practiced exclusively at Innocent Smile Dental Clinic, Ernakulam, now recognized as a referral center for the complex pediatric sedation cases. She completed her MDS from the Government Dental College, Trivandrum. Accompanied speaker, Dr. Kavita delivered keynote lecture at national and the state conference, sharing her expertise and inspiring the professional in the pediatric and preventive dentistry. Her commitment to postgraduate education makes her highly sought after trainer for orientation program, rapid reviews, and quiz competition is both national and the state level. She received a Distinguished Woman Award from the Indian Society of Pediatric and Preventive Dentistry and currently serves as Secretary of the Association of Pediatric Dentists in Kerala. Now it is Kerala. Dr. Kavita specializes in minimal invasive preventive restorative and endodontic procedure for primary young permanent teeth, ensuring advanced child-friendly dental care practices. Over to you, Dr. Kavita.
Thank you. Can I share my presentation?
Yeah. Make Dr. Kavita as a co-host. You want a recorded one or?
Anything is okay. You can play the recorded, or I'll share the recorded, or I'll take it.
We can play the recorded one. Technical team, please play the recorded version of Dr. Kavita's lecture.
I can do it from my side. Otherwise.
Yes, you can do it. Just a
Okay.
minute. Just a minute. They are doing, I think.
To one and all, I'm Dr. Kavita, and I'll be taking this rapid revision topic on the management of luxation injuries and avulsion. So, what's the good thing about this topic when it comes to your exams? Obviously, it's a very straightforward topic. There'll be no trick questions, right? There'll be a question on trauma, and you have to answer it. So, it's very easy to answer this topic. Second thing is, if you know all the flowcharts, it's very easy to explain also because there's very less of writing and a lot of flowcharts can be drawn on this topic. And most of them are based on one guideline, that is the IADT 2020 guidelines. So if we read the guidelines 2 to 3 times, then this topic just stays in our head, doesn't leave it at all. And actually, it's a life skill, right? This topic is very important, not only from the point of view of exam, but also when we get into practice. So that's another important point. And also the researchers working on this topic, they're very similar. So it's very easy to quote authors also when you're writing your essay on this topic, right? You can surely quote Nitish Tiwari sir on any topic, any area of this topic. So things like that. Now, these are the 4 links that I want you to enter and have a look. That is the general introduction, fractures and luxations of permanent teeth, avulsion of permanent teeth, and traumatic injuries to primary dentition. Everything regarding trauma is given in these guidelines. So what you all have to do is just read these 4 guidelines and you'll be thorough with trauma. So now coming to luxation injuries, there are basically 5 types of luxation injuries that we are concerned with. The first one is concussion, then is subluxation, then you have intrusive luxation, lateral luxation, and extrusive luxation. So in all these injuries, that is luxation injuries and avulsion injuries, what are the areas that actually get injured? The first and foremost is the pedial, because all of these involve injury to the periodontal ligament. The second is obviously the pulp tissue. The third is the cementum. Why? Because there could be a loss or alteration of the protective layer, and also as a post-traumatic response to inflammation, we can use a little bit of cement. Sometimes these luxation injuries are also coupled with injury to the alveolar process, which include ischemic and crushing injuries. Now, what are the factors that affect the clinical outcome of any of these injuries? There are three important factors, and this is very beautifully explained in this review article, that is expert consensus on the management of tooth luxation and avulsion. So what are the three factors? The three factors are, first is the stage of tooth development. Second is the distance of dislocation and mobility of the traumatic tooth would be the third factor. So coming to the stage of tooth development. Now what you have to understand in this is, obviously you decide the stage of tooth development based on molar stages of tooth development. So IADT uses stage 10 as a mature tooth and stage 9 or below as immature tooth. But what this study found out was that obviously a tooth with a larger apical foramen has a larger contact area for revascularization, and therefore the chances of regaining blood supply also would be higher in a tooth with a large apical foramen. So that is, a very young tooth is more likely to regain blood supply than an adolescent tooth and a mature tooth. So put it in short, a tooth which is in molar stage 9 and 10 will not have as good a prognosis as a tooth which is in molar stage 7 or 8. And obviously, a tooth which is in molar stage 7 would be called a very young tooth by this West China classification, and that has the best prognosis after an injury. Now, the second point is the distance of dislocation. Now, there is limited elasticity of the blood vessel. So, if this dislocation distance has exceeded the elastic limit of the blood vessel, then the blood vessel breaks. And therefore, in general, shorter the tooth dislocates, better would be the blood vessel recovery. Now, the third important factor would be the mobility of the traumatic tooth. As stated previously, there is limited elasticity of the blood vessel. So again, if the force has exceeded the elastic limit of the blood vessel, it has to break. And this breakage is usually associated with tooth mobility. So lesser the mobility of the tooth, better the blood vessel recovers. So again, a luxation tooth with less mobility will surely result in a better outcome than a one with more mobility. So whenever we think about pulp testing, this is again an interesting flowchart that is shared in this article. Obviously, you are supposed to check the pulp testing at the first visit. If it is positive in the first visit, which very rarely happens, then it indicates good outcome. But if it is negative, it doesn't mean that you need to perform endodontic procedures. That is the basic change in the IDT guideline in 2020. That there is minimal need for endodontic procedures in young permanent teeth. So if it is negative, what you need to do is you just follow it up in the next visit and then check for pulp testing. So if it's positive, it's a good outcome. But if it's a negative, again you need to evaluate other signs. Only then go ahead with endodontic procedures. Now, the next injury is concussion. What is concussion? It's just a tooth which has an associated trauma, but there is normal mobility. Tooth is tender to percussion and touch. Usually no treatment is needed, and all you need to do is monitor the pulp condition. The next injury being subluxation. Here also, the tooth is not displaced. The tooth is tender to touch or light tapping, and bleeding from the gingival crevice may be present. The tooth may not respond to pulp sensitivity testing initially, indicating a transient pulpal damage. So this is the term that you need to use when you're writing a trauma. The word transient is very important. And normally again, no treatment is needed. What you need to do is a passive and flexible splint to stabilize the tooth for up to 2 weeks. Now coming to a little more severe injuries, that is the lateral luxation, where the tooth is displaced laterally. So there is associated fracture of the alveolar bone and the tooth is frequently mobile. Multiple radiographs may be necessary. What you need to do in a lateral luxation case is stabilize the tooth for 4 weeks using a passive and a flexible split. When there is an extrusion, you need to reposition the tooth and stabilize it for 2 weeks. Monitor the pulp condition with pulp sensitivity test, and if the pulp becomes necrotic, do appropriate endodontic treatment only as per the stage of the root development. Now, when it comes to intrusion, we have different treatment approaches for teeth with open apices, that is immature teeth, and for teeth with closed apices, that are mature teeth. So when you have a tooth which is intruded and it is an immature teeth, that is, it has an open apex, you need to allow re-eruption without intervention, which is called spontaneous repositioning, irrespective of the degree of intrusion. If it does not re-erupt within 4 weeks, then you initiate orthodontic repositioning. And again, in a teeth with incomplete root formation, pulp revascularization usually occurs. So only after noting that the pulp has become necrotic or infected, only then do you go ahead with any kind of endodontic treatment. So in this, what you need to inform the parents is the need for multiple follow-up visits. We have a tooth which is intruded and a mature tooth. Then what's the treatment plan? You allow re-eruption without intervention if the tooth is intruded for up to less than 3 mm. And here, the time given, mind you, is a little. See, normally when we say trauma, we answer 2 weeks or 4 weeks for any of the conditions. But here, you give a re-eruption time of 8 weeks. And if it doesn't come out in 8 weeks, that is when you reposition surgically and split for 4 weeks with a passive flexible split. Alternatively, you can also use an orthodontic repositioning course before ankylosis develops. Now, if the tooth is intruded 3 to 7 mm, then you need to reposition surgically, preferably, or orthodontically. And if it is intruded beyond 7 mm, then you reposition surgically. But these teeth, where there is complete root formation, the pulp almost always becomes necrotic. So your root canal treatment should be started at 2 weeks or as soon as the position of the tooth allows us to use this corticosteroid antibiotic calcium hydroxide intracanal medication. Right? So just a quick table, and let's take a quick glance at it. When it is immature, no matter of the intrusion severity, we allow for spontaneous repositioning for 4 weeks and orthodontic repositioning after that. In mature teeth, up to 3 mm, we allow for spontaneous repositioning for 8 weeks, orthodontic or surgical repositioning for 3 to 7 mm, and more than 7 mm, we go for surgical repositioning. So maybe you can take a picture of this slide. And again, as I said, endodontic considerations for luxated teeth per se need not be intruded, could be any of them. If it is an open apex, then the root canal treatment should be avoided. And if it is a closed apex, you can go in for root canal treatment after placing an intracanal medicament for 1 to 2 weeks. Now, the next important injury obviously is avulsion. Now, coming to the etymology of avulsion, avulsion of permanent teeth is 0.5 to 16% of all dental injuries, and it is common in the age group of 7 to 14 years, affecting the maxillary central incisors. Only 15 cases of mandibular central incisors have been documented in 2022. Avulsion of primary teeth is 5.8% and 19.4%, according to studies by Holland. And male to female ratio is 2:1. Now, before we go into avulsion, there is this term that you all need to understand. What is it? Because there's a full original article which has taken time to give an appropriate terminology for just the time elapsed from avulsion of a permanent tooth to the replantation. Mind you, not to the time you get it or the time it comes to the clinic. It is from the time the tooth has avulsed to the time it is replanted into the alveolar socket. So this Delphi study revealed excellent agreement for the proposed term extra-alveolar period, right, with precise and clear recordings of both non-physiologic, that is the dry period, and physiologic, that is the wet period. So that total period is called total extra-alveolar period. Now coming to the treatment considerations, again you need to give two considerations: when the time of, that is when did the avulsion occur, and what was the extent of the closure at the time of avulsion. So before getting into the treatment of avulsion, obviously we need to understand what happens at the site of trauma, or what do you do when a patient or a parent calls you with an avulsed tooth. There are certain specific instructions that you need to give the patient. Again, a part of the IATT guidelines itself. What you need to tell them, important points here, would be to find the tooth and pick it up by the crown. And it is important to encourage them to replant the tooth immediately at the emergency site. And once it has been replanted, then you ask the patient to bite on a gauze or a handkerchief and come to the clinic. And if it is not possible, then try to educate them about the storage media that would be easily available to them, and get the tooth to you in the storage media. And also preferably record the time when all this has happened. That is, when the tooth fell and when did they put it into the storage media, what time they reached the clinic, because that is what is going to give you an idea of the total extra-alveolar time, and that is what is going to determine the prognosis of this avulsed tooth. So when you educate them about the storage media, you need to know what are the ideal requirements of a storage media. Obviously, it should be a material with low bacterial count, a physiologic osmolarity, neutral pH, has antioxidants, not packed with body fluids, not producing antibody reaction, and reduce the risk of post-reimplantation or absorption of antibodies. So you can classify these into two types: natural source and laboratory prepared. And you can also, based on cell viability, classify them as immediate short-term storage media and long-term storage media. And milk would be the easiest available for people, but you need to have an idea on what is HVSS. It's a sterile, physiologically balanced isotonic solution, which pH is 7 and osmolarity is 270 to 290. It has the ability to preserve and reconstitute medial cells, and that is why it is considered as a best storage medium. Now, there are conflicting studies on the best storage medium. Some say Viaspan, some say HPSS. I'll share a list of all the studies on storage media. So just go through them and have a look at different kind of available storage media. So these are all the studies that have taken place on water, egg albumin, Gatorade, and even contact lens solution, milk, Viaspan. Right, most of them would rate milk and HPSS and Viaspan as their safe to do storage media. Now, also read up on these narrative reviews about the storage medium for avulsed teeth. And this is also a nice systematic review on storage media prior to replantation. So all this is fine, but there are certain situations where you are not supposed to replant. What are they? When you have any periodontal disease, severe caries, you have an uncooperative patient, that means patient beyond cooperative abilities, and medical conditions like immunosuppressions and cardiac conditions. So what are the treatment guidelines for management of avulsed tooth? So again, the choice of treatment is related to the maturity of the root and the condition of the periodontal ligament cells. And what is the condition of the periodontal ligament cells dependent on? It is dependent on the time the tooth is out of the mouth and the storage medium in which it was kept. So these two factors is what you need to take when you are asked about what is going to determine the health of the PDL cell. What is critical? Minimizing the dry time for survival of PDL is obviously critical. So almost after half an hour of an extra oral dry time, most of the pedial cells will become non-viable. And so for this information regarding this time is very, very important. Now, from a clinical point of view, you can divide this viability of pedial cells into three categories. One is pedial cells are most likely viable. When does this happen? This happens when the tooth has been replanted immediately or a very short time, by 15 minutes at the site of accident. The second one is viable but compromised, where the tooth has been kept in a storage medium like milk, HPSS, saver tooth, saliva, saline, and the total extraoral dry time is less than 60 minutes. And pedial cells are most likely to be non-viable if the extraoral dry time has been more than 60 minutes. Now, let's come to the first situation, that is a tooth with a closed apex reimplanted at the site of trauma. The tooth that has been reimplanted at the site of injury or site of trauma before the patient's arrival, how it has to be managed: clean the injured area, verify the correct position, leave the tooth in place, administer LA. If it was replanted in the wrong socket, then do it again. Stabilize for 2 weeks and initiate root canal treatment within 2 weeks after reimplantation. Administer systemic antibiotics, check tetanus status, provide post-op follow-up information. Now, if the tooth has been kept in a physiologic storage medium, this is the first when it has already been replanted. The second condition is where it has been kept in a physiologic storage medium, in non-physiologic condition, but the extraoral dry time is less than 60 minutes. So here what's the first step? You transfer it to a physiologic medium, right? And then if there is visible contamination, rinse the root surface, check the avals for surface debris, remove debris by agitating it in the storage medium. Again, this is what has changed in IADT guidelines. In the older guideline, they asked us to remove all the pedial cell by scraping them. But here it is only agitating the tooth in the storage medium. And put or leave the tooth in the storage medium while taking administer LA, irrigate the socket, examine the socket if there is any fracture, remove the coagulum and replant the tooth slowly with slight digital pressure. Verify the correct position, stabilize for 2 weeks, and again initiate root canal treatment within 2 weeks after reimplantation. Antibiotic tetanus status remains the same as previous. We have the third situation. Mind me, all these are mature teeth. Okay, the vices are closed. So these children are, say, around 9 or 10 years old. And again, here is the only area which can be confusing, right? I told you there are no confusion. This is very clear. They can give you the age of the child and then ask you a trauma question, right? So all you need to know is at what age would be the tooth mature and what age would it be immature. So if you have an extraoral dry time of longer than 60 minutes, then you again remove the loose debris by agitating the tooth again, right? So again, I want you to take back this one small point that you don't scrape off the pedial cells, but you agitate and remove them. Administer LA again without vasoconstrictor, irrigate the socket, examine the alveolar socket, remove the coagulum, replant the tooth, verify the correct position, stabilize for 2 weeks, and then canal treatment. Now, delayed replantation obviously has poor prognosis, and the expected outcome here is ankylosis or root resorption. Now, what is the goal of replantation in these cases? Why do you do it even if it doesn't good prognosis? It is obviously for aesthetics and function while maintaining the alveolar bone contour, right? It is always the correct decision to replant the tooth. Replantation will keep future treatment options open. The tooth can always be extracted if needed. And you should also make patients aware of procedures like decoronation, which are procedures to maintain the alveolar bone so that it is available later for any kind of implants or any kind of treatment that needs to be performed eventually. And the rate of ankylosis and resorption also, it is quite unpredictable. So we must always first try to replant a tooth. Now, there are concerns as to whether there are risks of compromising healing by using a vasoconstrictor. However, when there is very little evidence to support omitting it, it is just recommended in the guidelines. Then the use of systemic antibiotics, again an important point of consideration. The use of systemic antibiotics after avulsion and replantation has been recommended to prevent infection-related reactions and to decrease the occurrence of inflammatory root resorption. Now, amoxicillin and penicillin are the first choices. Alternatively, you can consider other antibiotics for patients allergic to amoxicillin. Doxycycline is an appropriate antibiotic because of its antimicrobial, anti-inflammatory, and anti-resorptive effects. However, risk of discoloration is always present before systemic administration of tetracyclines. Also, we can use certain specific topical antibiotics. So, what are these root surface treatments? Topical treatment of the root surface with doxycycline before replantation has been reported to significantly increase the frequency of complete pulp revascularization. It's a very, very old paper, right from 1990. So, in contrast, systemic treatment, however, failed to prevent or eliminate contamination with microorganisms. But prescription of systemic doxycycline can be justified to promote periodontal healing in avulsed tooth according to the current guidelines. So why should you do this root canal after 2 weeks? Why not immediately? Replanted teeth should be stabilized for a period of 2 weeks depending on the length and degree of maturation of tooth. And what happens in this 2 weeks? More than 60% of the mechanical properties of the injured PDL will return. So why you should do an RCT after 7 days? Based on the assumption that calcium hydroxide may impair periodontal healing due to different hydroxyl ions through the dental tube, it was recommended to schedule the initiation of 7 to 10 days by Anderson in 2012. So in order to make the initial process on one hand, but to initiate treatment before pulp space infection is established on the other hand. Avulsion of tooth inevitably leads to necrosis of the disrupted pulp. In mature teeth with closed apex, revascularization cannot occur after. Instead, regardless of whether the crown is intact or not, bacteria that contaminated the surface of the root during extra-alveolar period will enter the necrotic pulp tissue. Right? So this infection of pulp space is believed to be established as early as 2 to 3 weeks. And so there is consensus, that early root canal treatment is mandatory in these fully developed teeth. So it is not optional, but it is mandatory. What can we do to improve the life of these teeth or to improve the periodontal healing? In contrast to calcium hydroxide. Why? Because calcium hydroxide, as I said, could leach out through the dentinal tubules and impair the periodontal healing. So leather mix has been placed immediately or in a short time following replantation. And its main preventive mechanism does not rely on the antibacterial effect but on the inhibition of odontoblast by detaching the resorbing cells from the root surface, right? And odonto paste also has been developed in Australia but not available here. So in cases where the root apex is open, the only step is different, that is performing the root canal treatment. Why? Because the likelihood of natural revascularization may exceed even 40% under ideal conditions with an apical foramen greater than 2.75 mm and a pulp length less than 17 mm, but may drop below 10% in immature roots with a distance to be revascularized of more than 19.5 mm. So these are the numbers which you need to remember: 2.75 foramen diameter and 17 mm length. That would be safe for spontaneous revascularization, whereas it may drop below 10% in immature roots where a distance or length of the root is more than 19.5 mm. A small note on the type of splints. I'm not really going into the detail of all this, but composite splint and wire splint are what we normally do. Where they are not avoided, they are not avoided. If they are avoided, then there is, cases of unavailability. Again, very, very advantageous because most of the dental offices will have it. And what you need to remember is there are aseptic splints also, like fiber splints. There's also a titanium trauma splint. These splints will reduce the quantity of composite material, and also they're very easy to apply. They're more aesthetic, the fiber splints. So these are all options when the patient is also concerned about the TTS. So it is not aesthetic, but it will reduce the quantity of composite. It's easier to apply, and it helps to maintain your hygiene much nicer. Right now, this is a table again, which will tell you what is the observation time for each injury, right? What is the injuries, the concussion, subluxation, extrusion, lateral luxation, intrusion, and avulsion. How it is in a permanent mature and an immature tooth. What is R? It is the need for radiograph. So you need to take a radiograph at 2, 4, 3 months, 6 months, 1 year, 3 years, and 5 years. And when you need to splint is you need to splint for 2 weeks in cases of subluxation and extrusion, and 4 weeks in lateral luxation, intrusion, and 2 weeks again in avulsion. So this one table will at just a single glance tell you everything about how you need to follow it up, when you need to remove the splint, and what are the different types of observations for both primary as well as mature as well as immature tooth. When do you perform the RCT? Everything is very nicely, it's simply given in this table. So this is something again which you can take back after today's class. So that's all I have for you. Thank you. Best wishes to all of you.
Thank you, Dr. Kavita, for a well-structured presentation on luxation and the avulsion injuries. Any question needs to be asked by postgraduate? We have, there are a few questions you can answer. How much time we should wait before the ortho treatment? It's already, ma'am has already given the answer, I think so.
Most of it I have answered.
Yes. Can we have a certificate? Dr. Kavita, please accept this certificate of appreciation from the ISPPD office for your hard lecture. Nicely presented lecture. Thank you. Thank you, Dr. Kavita. Moving on to our next speaker. Can we have a slide? Yeah. Our next speaker is Dr. Pavitra Devi. She is currently working as an assistant professor in the PGMER Chandigarh. She has completed her post-graduation from PGA and awarded a bronze medal for the academic excellence. She has also, in past, she was a senior resident at All India Medical Institute, New Delhi. Work as a research scientist in the ICMR funded project at AIIMS New Delhi. Serve as an assistant professor at AIIMS, that is a new AIIMS, that is CAP-FIMS, that is for Central Armed Forces, New Delhi. Authored and co-authored more than 18 international publications in the peer-reviewed journal. Her area of interest is pediatric dentistry, include dental trauma, pediatric endodontics, dental management of children with special healthcare need. Pavitra?
Yes, sir. Thank you so for the warm welcome.
Welcome, Pavitra. You can start your presentation.
Is my slide visible? Am I audible, sir?
Yeah.
So, a very good morning to one and all present here. The topic of my today's presentation is traumatic dental injuries in primary dentition. So, after all the excellent lectures by eminent speakers in dental trauma, my job today is really simplified. So, through this presentation, I'm just going to brush up the important concepts and treatment protocol pertaining to traumatic dental injuries in primary dentition, which we all must agree is an important entity in dental traumatology. So this is my roadmap of the presentation, starting with the introduction, where I'll be talking about the epidemiology and importance of primary dentition trauma. Classification, I hope you all enjoyed listening to a wonderful lecture given by Nitesh Tiwari sir. So I have nothing to talk about. We'll focus more on the diagnosis, in which I'll be talking about the history, how to take the clinical examination, and the role of radiographic assessment. Next will be the core discussion area, where I have broadly classified each injury into 3 broad domains. One is crown and root fractures. Next is the luxation injuries, and avulsion as a separate entity for easy understanding. So after that, there are certain common protocols, no matter what type of injury it is. There are certain common protocols that IADT has suggested regarding the antibiotic usage. What about the antibiotic usage in primary dentition trauma? Parental home care instructions, parental education, and certain follow-up protocols. So we'll be discussing all those common protocols together. And towards the end of the presentation, I'll be discussing about the sequel of traumatic dental injuries in primary dentition. So when I say sequel of injury to the tooth itself and the sequel of injury to the developing permanent tooth bud. So this is how the presentation is going to be. Now, we all know traumatic dental injuries, TDI in primary dentition, is very common but often a neglected public health problem. If you can see, of all the physical injuries in children aged 0 to 6 years, the oral injuries constitute 18%. And interestingly, a systematic review by Patnana et al. In 2021, a systematic review and meta-analysis, they have found that this was done by Indian authors. So they have found that the global prevalence of traumatic dental injury in primary dentition 24.2%, which is quite higher. And what are the most common causes? As we all know, unintentional falls, collisions, and falls during leisure activities. And if you look at the peak age range during which the trauma occurs, it's between 2 and 6 years of age. As seen in this graph, the peak incidence that usually happens around 2 to 3 years of age. Why? Because during that stage, the motor development starts in the child. The child will be able to stand, walk, run independently, during which the trauma most commonly occurs. Male children are found to have higher trauma incidence than the female children. And maxillary primary incisors are found to be the most commonly involved. If you look at the risk factors, there are certain risk factors like increased overjet, inadequate lip coverage, very high activity of the children during that age range. So all these are considered as risk factors for such high incidence of trauma in primary dentition. Now, this slide is very important because so far in the previous lectures, we have been discussing about trauma management in primary dentition, young permanent tooth and all. Permanent dentition, young permanent tooth and all. But when it comes to primary dentition, these are the factors that has to be considered because these factors influence the management of trauma in primary dentition. So first and foremost is your treatment plan should be basically dependent on these factors. So the first one is short functional life. Before deciding the treatment plan, we should know that the fact that the primary teeth is going to be there in the oral cavity for a very limited period of time. So treatment plan should be based on that fact. And the second and most important is its close proximity to the developing permanent tooth germ. This is one of the important factors to be considered because the trauma by itself or the treatment that we are going to render both may cause damage to the permanent tooth germ that is underlying just very close to the injured tooth. And another very, very important factor when it comes to traumatic dental injury in primary dentition is the child's level of cooperation. Because we may identify the trauma, we may decide the treatment plan, we may come to a proper diagnosis, but everything will fall in place. You will be able to deliver a proper treatment only when the child is able to be cooperative. So child's ability to cooperate is also an important factor to be considered while you decide a treatment plan. Because behavior management is very challenging in this scenario because the child and the parent, the entire family, whoever is involved will be in a very stressful and anxious state. So in such a state, behavior management becomes all the more very challenging. So this is, I would say, one of the most important factors to be considered. So by saying that, the fourth factor is the clinician skill and experience. So we need to have a skilled and trained pediatric dental team to manage such a situation. This is most important for managing patient as well as parent anxiety in that emergency situation. So before deciding a treatment plan, especially in trauma to primary dentition, I would recommend all of you to consider these factors. Next, moving on to the diagnosis. So thankfully, I've given some space to discuss in detail about the diagnosis. So diagnosis is very, very important because if you see retrospectively, most of the complications in trauma that usually occurs because of improper initial documentation or the diagnosis we would have missed out during the initial presentation. So that leads to complications. So diagnosis is the important factor, which usually comprises of thorough history taking, detailed clinical examination, and appropriate radiographic examination, because diagnosis that makes the foundation for the treatment plan. So we need to be very clear in taking a thorough history, detailed clinical examination and radiographic examination. One by one, I'll be explaining. So when we talk about history taking, we should elicit a careful medical, dental, and accident history. The question should be in a way that when did the injury happen? We should probe the patient, because as I already said, they are all in an anxious state. They are all in a stressful situation. So unless you don't probe them, they are not going to give you any detailed history. And without detailed history, whatever stones we are going to step ahead, it's not going to pay. So we should probe them with questions like, when did the trauma happen? How did it happen? And where did it happen? Because these questions and the answers to these questions are very important to assess the severity of trauma and the contamination risk, as well as any other associated injuries. Because if they say that there was a road traffic accident, that will not just end up in a very minor dental trauma. So we have to think in a comprehensive way. So eliciting history by asking these questions are very, very important. And when a patient comes to you for trauma evaluation, especially pediatric dental trauma, it is not just the intraoral tooth structures, soft tissues, and extraoral tissues. We should analyze the child in a more comprehensive way. So during the baseline examination after a thorough history taking, we should examine the head, neck, and other extraoral structures, especially for bony and soft tissue injuries. We should all, again, now here comes a set of questions, like whether there was a history of loss of consciousness, history of vomiting, history of blurred vision, history of dizziness. So all these things should also be asked when the patient is presenting to you at the baseline. Because in tertiary care centers, like where we are working, the referral channel is like the patient goes to the trauma center, and then they will do all those neurological examination, and once it's cleared from there, they come to us. But then in few cases, the patient directly come to us. So it is our responsibility that we record all these major domains as well, not just the tooth and oral cavity. So we should ask all these histories, and then we should be very cautious about concomitant head injury, should be aware of it. It's not that every patient will be having this, but still we have to be very alert about the concomitant head injury, facial fractures, missing tooth fragments, which I'll be explaining in detail in the subsequent slides, and lacerations. So if you are doubtful about any of these major aspects, so seek medical attention wherever necessary and immediately. Dental treatment comes next to it. Now, soft tissue injury. So soft tissue injuries are also very common, but often overlooked, again, because of the tendency, we tend to see only at the tooth structure into the oral cavity. So we forget to see the surrounding structure. So examining and taking detailed clinical examination of soft tissue injuries are also very, very important. So it's essential to identify, diagnose, and record extraoral and intraoral soft tissue injuries. For example, lips, check for lacerations, hematomas, and embedded tooth fragments. If you suspect, in case of crown fractures, class 1, class 2, class 3 fractures, if you suspect that the tooth fragment might be embedded within the soft tissue like lip, cheek, tongue, or anywhere, so it's better to get an IUPA done, X-ray done, and then confirm the presence or absence of the tooth fragment. Similarly, for oral mucosa, gingiva, and tongue laceration, so this is a case of tongue laceration in a 2-year-old child because of dental trauma reported just last week. And you should also assess for the frenula, again for lacerations and hematomas, because soft tissue injury at the time of presentation, they may appear like a minor injury, but definitely they might be hiding something major beneath it. For example, you all must be knowing that if you are able to see a hematoma in the lingual sulcus, lingual frenulum, it appears to be like a minor injury, but then the underlying cause will be the mandibular fracture. Most of the cases, the mandibular fracture will be represented clinically as a sublingual hematoma. So that is why, assessing soft tissue injuries are also equally important. By saying that, the another important aspect for recording soft tissue injury is soft tissue injury as well as detailed history. So you can rule out medico-legal issues. For example, if you are taking a detailed history and you are assessing the soft tissue injuries, if you are finding that the history given by the parent or the caregiver is not matching with the clinical presentation, and it is there are abnormal presentation, abnormal bruises, and the history is not matching, and the child is coming up with repeated trauma in the same pattern, you can always suspect a case of child abuse. So if you do not widen your view and assess in all these angles, you may miss out important diagnosis. So that is why it's not just a recording. Clinical photography is strongly recommended wherever it is applicable, especially just now I said about medico-legal issues like child abuse. So it's very, very important to have a clinical photography record. So the topic traumatic dental injury in primary dentition, it's not just as simple as like how it appears. It has so much thing inside when we go in detail. So this is what I want to talk about soft tissue injury. Next is intraoral examination. What is recommended? Extraoral, intraoral photographs. When you're now we have done with the extraoral head and neck assessment, extraoral assessment, extraoral soft tissue assessment. Now we are going to the intraoral area. So see where that intraoral examination part is coming down after 1, 2, 3, 4th place. But we usually tend to examine intraorally at the very first place when the patient comes, when a trauma patient comes. So try to go in that sequence. So now we have reached to the intraoral examination. So what is recommended, as I said, photography. And when you start assessing the tooth, particular injured tooth, so you have to assess for tooth mobility, tenderness to pressure, manual pressure, its position and displacement, all these things to be recorded. Record the color of injured and uninjured tooth at each visit. So the importance of recording the color, the discoloration, I'll be discussing later. Now, what is not recommended? Ideally, when a trauma patient comes, if it is a permanent tooth or a young permanent tooth, we basically go for certain set of baseline investigations in which pulse sensibility testing is the important one. Baseline pulse sensibility testing, no matter whether the tooth is responding or not. One of the PG students had asked this question in Kavita ma'am's lecture, and ma'am had answered that beautifully. So whether the in case of permanent tooth or young for a permanent tooth, whether the tooth is initially responding or not, it's always better to have a baseline pulse sensibility testing, right? But in case of permanent primary tooth, pulse sensibility testing are unreliable and that was not found to be valid. So it is not needed to perform a pulse sensibility testing in a primary tooth trauma, especially when a child is again in a stressful situation. And of course, that's the results are not going to be reliable. Next comes the radiograph, which is again an important domain for the diagnosis. So this is an important adjuvant and it may affect the treatment plan, of course. Clinically, what we are finding and radiographically, what we are finding, you correlate all together and come to a appropriate diagnosis, right? So the acceptable radiograph is the occlusal exposure. Why? Because as I was keeping on telling that the child and the caregiver or the parent are in a very stressful situation, they may not be able to hold a periapical radiograph properly into the oral cavity. So it's better to have an occlusal exposure. If they're able to hold and get a periapical X-ray, then it's well and good. Otherwise, occlusal exposure is also acceptable. Now, soft tissue injury, as I already said, if you suspect any tooth fragment embedded into the soft tissues like lip or anything, immediately get an X-ray done and verify it and plan for the surgical removal. Now, apart from these importance of radiograph in trauma diagnosis, when as far as the primary tooth trauma is involved, the radiographs play a major role in assessing the relationship, the position of injured primary tooth with the underlying permanent tooth. So how do you assess, especially in cases of intrusion? If you can look at the first image, if the on the radiograph, if the injured tooth is appeared foreshortened when compared with the non-injured contralateral, it means that the labial, the root tip of the tooth has penetrated in a labial direction. So it has not moved towards the permanent tooth, but it has moved labially. So that is why it's appearing foreshortened. On the other hand, if the injured tooth on the X-ray appeared elongated when compared to the non-injured counterpart, it means the tooth has penetrated into the follicle of the erupting permanent tooth, and the severity of damage to the permanent tooth in such cases is higher. So especially in cases of intrusion, the tooth is intruded, but you may not know whether it is intruded in a labial direction or in the palatal direction towards the tooth bud. So diagnosing with the help of a radiograph is very essential. I hope you're clear. Now, till now, we have talked about introduction, epidemiology, and factors to be considered while deciding a treatment plan for primary tooth trauma. And then we have talked about the diagnosis. So here I'm just taking a few minutes to summarize what we have learned so far, because primary tooth trauma as such is it can be an essay question, or it can be asked in short notes as well. To summarize, if you are asked about the diagnosis and clinical examination and all, so you can easily write this. First is assess thoroughly. Take full medical history, dental and accident history, examine head, neck, and soft tissues. Second is document everything. Photographic injuries, record tooth color, mobility, and position at every visit. Avoid unreliable tests, as I said, tests like pulse sensibility testing. Stay vigilant. You have to be very clear in taking the history and correlating with it with the presentation of the trauma. So check for consistency between the history and the injuries. Refer promptly if non-accidental injury is suspected. And then inform parents. So everything should be informed. What is the condition of the child, condition of the tooth, and what are the treatment plan that what is the treatment plan that is appropriate, and what are the expected outcome, and what are the expected outcome in the permanent tooth. So all these things should be explained should be informed to the parents beforehand. Right? Now we are moving on to the treatment guidelines of traumatic dental injuries in primary dentition. According to this section is mostly from the IADT guidelines. So here I have categorized it into crown and root fractures, where I'll be covering about crown fractures, root fractures, and alveolar fractures. And then I'll move on to the luxation injuries like concussion, subluxation, extrusion, lateral luxation and intrusion, and avulsion. Crown fractures, there are 3 different types of crown fractures. One is the enamel fracture. Here the fracture line is, these things are already very well explained in detail by Hitesh sir and Kavita ma'am, but still I'll just brush up, and there are a few points to be noted down in terms of primary dentition trauma. So we'll focus only on that. So enamel fracture, this is the simplest form of fracture. You just round off or do the enameloplasty, no x-rays needed and no follow-ups needed, as long as there is no unfavorable outcome, which is reported very less in case of enamel fracture, right? Next, we'll move on to the enamel dentin fracture, which we call it as uncomplicated crown fracture. Here, what is the concern? Here, the enamel and dentin both are fractured, and the concern is the exposed dentin. So, our treatment plan should be majorly dependent on sealing the exposed dentin, prevent bacterial contamination, and reduce the sensitivity. So, these are the treatment objectives. So, for that, here, what about the X-ray? You can take baseline X-ray, optional, depending upon the need. And again, if you are suspicious about the missing fragment, you can go for a soft tissue. Treatment, as I already said, the treatment objective should be sealing the exposed dentin to reduce further bacterial contamination, and then reduce the sensitivity. To cover the exposed dentin with glass ionomer cement or composite. Follow-up will be done at 6 to 8 weeks, and radiographic follow-up can be done if any unfavorable outcome is suspected. And what are those unfavorable outcomes? I'll show you in a slide in the upcoming slides. So right now we are in crown fracture. We are looking at uncomplicated crown fracture. Now moving on to the complicated crown fracture. When the word complicated comes, it means pulp is exposed, be it crown fracture, crown root fracture, or anything, right? So here, enamel, dentin, and pulp, all 3 are fractured. So that is why the pulp is exposed, and that is why we call it as complicated crown fracture. Here, the baseline radiograph, either periapical or occlusal X-ray, is mandatory at the baseline. And treatment, if it depends on the degree of pulpal exposure. If it is small exposure, you can go with partial pulpotomy with non-setting calcium hydroxide paste and composite. And if it is a large exposure, you can go for cervical pulpotomy. Once the trauma has reached to this complicated level, then follow-up is closely monitored. The tooth is closely monitored. So clinical follow-up should be at 1 week, 4 to 8 weeks, and 1 year. If you have done partial pulpotomy or cervical pulpotomy, then subsequent radiographic assessment is also mandatory to see the treatment outcome. So radiographic follow-up at 1 year is recommended. I hope you're clear. Next is crown root fractures. So we have seen crown fractures complicated and uncomplicated. Now we are seeing crown root fractures. And again, this can also be complicated or uncomplicated depending on the exposure of pulp, whether the pulp is exposed or not, right? So again, baseline radiograph is mandatory. You can take a baseline periapical or occlusal radiograph. Now, moving on to the treatment. So there is a case of crown root fracture. In such case, you will have the tooth is fractured and the fragments will be mobile, right? So to evaluate, first of all, you have to administer LA. See, when we are talking about treatment, it's very simple. It is all given in the guidelines and it is almost matching with all those treatment plans in the permanent and young primary tooth. It is all, there is nothing, not much of a difference, but I am again stressing all these treatments will be done or will be applicable only depending on the cooperation level of the patient, because right now we are talking about trauma in children. The child may be of 1 year, 2 years, 3 years, 4 years, in a pre-cooperative stage, early cooperative stage, we may not know. So depending on the child's ability to cooperate, parents' concern, your confidence to manage the case, so all these factors play a major role, and then only you can proceed to all these guideline given treatment. So first, you remove the loose fragment and evaluate. Once you remove that mobile fragment, while evaluating, you can have two options. One is, after removing, you may think that the tooth is restorable, right? So if it is restorable, it has enough sufficient tooth structures. And if it is an uncomplicated fracture, uncomplicated restorable fracture, you can cover the exposed dentin with GIC. And if it is a complicated fracture, which is restorable, the tooth is restorable, again, you can go for pulpotomy, or depending on the degree of exposure, if too much pulp is exposed, it's better to go for a pulpectomy. If unrestorable, in both these scenarios, it's better to go for extraction under LA. So the follow-up protocol, 1 week, 6 to 8 weeks, and 1 year. Radiographic evaluation, as I already said, if you are going to intervene endodontically, it's better to have a subsequent radiographic follow-up, which is recommended soon after 1 year of treatment. Now moving on to the root fractures. Here, the clinical feature, how does this injured tooth will appear? It depends on the location of the fracture. If the location is at the apical third or the middle third, the coronal fragment may not be mobile, it may be stable, and this finding will be accidentally or incidentally seen on an IOP, right? So if the same fracture line is more cervically placed, the coronal fragment is going to be excessively mobile. Again, the treatment plan depends on the mobility, severity of the mobility of the coronal fragment. If it is not mobile and the fracture line is somewhere deep down the middle or the apical third, we are not going to unnecessarily intervene. But most commonly, fracture occurs at that stage, at that mid-root or apical third. If at all, if the fracture line is, as you can see in this X-ray, if it is more cervical and the coronal fragment is mobile, so what are all the treatment, how to manage such a case of root fracture in primary dentition? So treatment, coronal fragment, if it is not displaced, not mobile, as I said, no treatment is needed, just wait and watch. You can give home care instructions to the parents. What are they? I'll be explaining later. Now, the other scenario, if the coronal fragment of a root fracture is displaced and it's mobile, then again here you have two options. One, depending on the severity, if it is severely displaced and severely mobile, it's better to extract the coronal fragment. On the other hand, if the coronal fragment is not, it's minimally displaced and the mobility is within normal limit, you are able to control the mobility, then it's better to go for gentle repositioning of the fragment and do a flexible splinting. So till now, here is the first place where we are talking about splinting in primary dentition as recommended by the IADT guidelines, right? So for root fracture, if the coronal fragment is minimally not excessively mobile and not excessively displaced. If you are able to manipulate it, just gently reposition and splint. So splinting duration is for 4 weeks. So there are 3 conditions where you will be splinting, where the guideline recommends splinting, like root fracture, alveolar fracture, lateral luxation. But all these 3 splinting, the splinting duration is 4 weeks. Just you can remember that. So this is the treatment suggested by IADT for root fractures in primary dentition. Now we are moving on to the alveolar fracture. So here the clinical feature appears when the tooth is injured. There is a fracture of labial or palatal alveolar bone. Again, similarly here what happens when the alveolar segment, it may be either labial alveolar bone or palatal alveolar bone, when it is fractured, there will be mobility and displacement of the entire segment with multiple teeth involved, and all those multiple teeth will be mobile. And they will be severely displaced, they will be severely mobile along with the segment. That is how it basically presents clinically, right? When we talk about the radiographic recommendation, baseline radiograph is a must. And if it is a labial bone fracture, you can take a lateral radiograph where in the X-ray you can see the tooth has fractured the labial cortical plate, and that's clearly visible on the lateral radiograph. This is one. So far we are discussing about periapical and occlusal. So here comes one alternative, the lateral radiograph for alveolar bone fracture protection, right? Now, treatment, again, you have to reposition the segment, the teeth, and splinting. The second splinting place is for alveolar fracture in primary dentition. So again, the duration is for 4 weeks. Follow-up at 1 week, 4 weeks, 8 weeks, 1 year. As the severity of the injury increases, the follow-up, the period of the duration of follow-up becomes very confined. So 1 year, 4 years, 1 week, 4 weeks, 8 weeks, and 1 year. And at the age of 6 years, we need to get one follow-up done to assess the status of erupting permanent tooth, whether it is erupting in a proper way or does it have any developmental disturbances, so and so. So that has to be evaluated when the patient turns 6 years of age. Now moving on to the most important aspect of TDI in primary dentition, luxation injury. Why? Why is this very important? Because this type of injury, luxation injury, is the most common type of injury in primary dentition, because the factors, the bone is basically very fragile, resilient. The supportive tissues are resilient in during primary dentition stage. When the child is growing, and the supporting structures are very resilient, and the root is very short, the bone is very elastic. So all these factors, because of all these factors, luxation injuries are the most common type of TDI in primary dentition. So it was already explained in previous lecture. I'll just briefly explain. So first, luxation injury, concussion, subluxation. So in your theoretical point of view, or most commonly in practical point of view, practical examination or viva, this can be one of the most commonly asked questions. What is the difference between concussion and subluxation, right? So in concussion, see, in both the injuries, when you talk about luxation injury, when the term luxation emerges, it means there is some damage to the periodontal ligament, right? But the type of injury, when terminologies we have given, it all depends on the severity, how much that periodontium is damaged because of trauma, right? So in case of concussion, there is minimal damage to the periodontium. The tooth is just tender to touch because the trauma has occurred. There is some impact on the periodontal ligament. There is some injury to the periodontal ligament. So the tooth is definitely going to be tender on palpation or percussion, right? But the tooth will not be mobile. It will not be displaced. It will not be mobile. It will be there in its place, but just that it will be tender. So that is concussion. Whereas on the other hand, what is subluxation? The tooth, again, here the periodontal tissues are damaged, but it's somewhat more damaged than the concussion. So here the tooth will not be displaced. That is why we call it as subluxation. If it is displaced in any of the direction, then we'll go for the other terminologies like extrusion, intrusion, etc. It is not displaced, so that is why we call it as subluxation. However, the tooth is mobile because the impact of trauma is much more than that of concussion, right? The another clinical important point to differentiate subluxation is because of the severity of damage to the periodontal ligament and supporting tissues, there will be bleeding from the gingival crevice, which is one of the clear-cut diagnostic factors for subluxation. I hope you're clear between concussion and subluxation. If it is permanent tooth or young permanent teeth, in cases of subluxation, IIDT recommends splinting for 2 weeks, but in case of primary trauma, subluxation does not require any splinting. We can keep the patient under follow-up. X-rays, if it depends, radiographic assessment depends on the clinical scenario. If you would like to take one baseline X-ray, it's well and good. No splinting needed. The patient has to be reassured, advised to be maintained on soft diet and proper oral hygiene instructions. Moving on to the extrusive luxation. So here in this clinical picture, as you can see, the extrusive luxation of 6-1. The clinical features are partially displaced tooth from the socket in the axial direction. Direction matters during luxation, right? If it is extrusive luxation, you call it as extrusive luxation only when the tooth is displaced in the axial direction from the socket. There will be excessive mobility. Occlusal interference may be there. So your treatment plan again depends on these clinical features like excessive how mobile that tooth, how much, what is the degree of mobility, and whether it is interfering with the occlusion or not. So all these factors are going to it may not be appearing very important, but all these factors are going to decide your treatment plan, right? So in case of extrusive luxation, excessive mobility will be there. Occlusal interference may or may not be there. Radiograph, you have to take one baseline radiograph, and in that radiograph, what will be able to see the tooth, as I said, the tooth is extruded in the luxated in the axial direction, displaced in the axial direction. So there in the apical region, there will be an elongation of the pedial space. As you can see in the diagrammatic representation, there is a slightly increased pedial space in the apical direction. This also happens in lateral luxation, but how to differentiate, I'll tell it in the next slide. So this is all about extrusive luxation. What is the treatment? If the tooth is not very mobile and it is not interfering, just allow the tooth to reposition spontaneously by itself. On the other hand, if it is severely mobile and extrusion is more than 3 mm and it is interfering with the occlusion, it's better to go for extraction under LA. The clinical follow-up at 1 week, 6 to 8 weeks, and 1 year. Radiographic follow-up if at all any pathology is suspected following trauma. I hope you're clear with concussion, subluxation, and extrusive luxation. Now we are moving on to an important aspect, lateral luxation, right? So here, what happens clinically? The displaced tooth is usually in either palatal or labial direction. In case of extrusive luxation, it's in the axial direction, right? So here, in case of lateral luxation, it can be either ways, either in the palatal direction or in the labial direction. One important factor is the tooth will be immobile. If you can see in the third image, that is the first clinical picture, where 6-1 is laterally luxated, but if you suddenly see, it appears like the tooth is extruded. It may be called as extrusive luxation, but how will you differentiate? One is the direction of displacement, but here the direction seems to be axial. Now here, so how will you differentiate? The important point is whenever there is lateral luxation, be it in the palatal direction or in the labial direction, the root tip gets locked between the fractured alveolar bone. If you can see in the diagrammatic representation, be it in the first image or in the second image, first image is towards the palatal bone, second image is towards the labial bone. In both the scenarios, there will be a fracture of alveolar bone also. So the tooth root tip will be locked. So in such cases where the lateral luxation has happened, the tooth mobility is not the tooth may not be as mobile as you see in the extrusive luxation. The tooth is basically immobile because it got locked between the fractured alveolar bone plate. Okay, so this is one important point to remember. And occlusal interference, again, because of this change in direction, there may be occlusal interference. So baseline radiograph is necessary. Again, on the IOPA, if you can see in the IOPA, there is increased pedial space at the apical region, which is similar to extrusion. So how will you clinically differentiate? That's what I explained right now. So again, the treatment, it's not interfering. Allow it for spontaneous repositioning. Usually the reposition happens within a period of 6 months, duration of 6 months. If the tooth is luxated either in a palatal or labial direction, severe displacement, here you have two options. One, extraction when there is a risk of ingestion or aspiration, or if the severity, displacement, everything is under control, if you're able to manipulate, then gently reposition and do the flexible splinting. So here comes the third splinting protocol in case of primary dentation trauma. The first one we saw for alveolar fracture, the second one we saw for root fracture, and third one for lateral luxation. For all these three splinting protocols, the splinting duration is 4 weeks. Next is most severe form of injury in primary dentation is intrusive luxation. Clinically, the displaced tooth usually it is displaced through labial bone in the labial direction, or it will get impinged on the follicular space of developing permanent tooth. So this is how the intrusion is going to present to you. Okay. So the tooth, how to diagnose it on the X-ray, the foreshortening and elongation I already explained in the previous slide during radiographic exam. So the tooth clinically it's almost disappeared. It can, if it is intruded completely, you can palpate on the labial aspect. Radiographic examination I just mentioned. Now coming to the treatment. Historically, if you see till the guidelines, IADT guidelines till 2012 guidelines, and that we have been following for the consecutive years, historically the intruded primary tooth was supposed to be extracted irrespective of the degree of intrusion, okay, and the level of intrusion. But in the new guidelines, new in the sense the guidelines, IADT guidelines in 2020, it's been about 6 years. Here, this is one of the major changes that IADT had done from previous guideline to the current guideline, 2020 guideline. What? In the previous guideline, intruded primary tooth was supposed to be extracted irrespective of the degree of intrusion, no matter what. But now, in the current guidelines, irrespective of degree of intrusion, no matter if the tooth is severely intruded, mildly intruded, moderately intruded, the tooth has to be observed for spontaneous repositioning. No extraction has to be performed, and spontaneous repositioning can happen within 6 months to 1 year. So follow up 1 week, 6 to 8 weeks, 6 months, and 1 year. At 6 years to monitor the eruption of permanent tooth. Classification of intruded tooth, one classification by one arts. Grade 1, mild intrusion in which more than 50% of the crown is visible. Grade 2, moderate intrusion in which less than 50% of the crown is visible in the second image. Grade 3, severe intrusion where complete clinical crown is not visible and it's inside. So here, when the patient comes to you, presents to you with a grade 3 intrusion, please be very careful to differentiate it from avulsion, because again, it's a tendency. Just at the moment we look at the clinical presentation, we may think of avulsion, but the tooth may be lying very deep inside. Okay, so always when you have a severely intruded case, don't mix up with avulsion. So here coming on to the most important, and again severe luxation injury in primary dentation, and in exam point of view, examiners, I think they would love asking the treatment plan for avulsed primary tooth. Now, if the tooth is avulsed, you should follow a search protocol. Avulsed in the sense, even in cases of crown fractures where you are not able to locate the tooth fragment, similarly where you are not able to locate the knocked out tooth. So the search protocol is explore the location. Tooth may be embedded into the lip, tongue, nose, or maybe aspirated. So it's always to ask to the attender whether it was a witnessed trauma or unwitnessed trauma, whether they are very sure where the tooth is lying, they are having the tooth in hand, or they disposed the tooth, are they sure that they saw the tooth. So these things are very important, okay? And if the tooth is not found and it was an unwitnessed trauma, even the caregiver is not aware of that knocked out tooth, it's better to have a medical referral on a safer side. Now, radiographically, baseline assessment, you can have one X-ray to assess the for the baseline recording of developing tooth, permanent tooth. Treatment, according to the guidelines IADT 2020, till now, guidelines suggest avulsed primary tooth should not be reimplanted, and the clinical follow-up examination can be done after 6 to 8 weeks. And again, at the year of 6, you can monitor the eruption of permanent tooth. But keeping the guidelines aside, Awal's primary tooth should not be reimplanted. Whether it should be reimplanted or not reimplanted, there are few reviews, systematic review articles that are in favor of that have been showing successful outcomes in favor of reimplanted Awal's primary tooth. But if you go in detail, so all those studies included in these reviews, systematic reviews, are of very low quality, and then eventually the overall quality of the review, quality of evidence is very low to low. So currently, reimplantation of Awal's primary teeth is not an evidence-based care. The evidence is not very supportive and very strong for this aspect. So this treatment plan cannot be formally recommended. So right now, the treatment for Awal's primary tooth, that it should not be reimplanted. But however, we are trying to gather the evidence. We, in the sense, the dental trauma experts and researchers, whoever is interested, they are all now trying to generate evidence for in this aspect to show successful outcomes in case of Awal's primary teeth. So maybe in future, if the IADT plans to come up with a new guideline, they may reconsider it, and potentially they may include reimplantation of Awal's primary tooth. We have to wait and watch. But right now, for exam point of view, Awal's primary tooth should not be reimplanted. If this question is being asked in Viva, you have some basic knowledge of currently what is happening. You can just put forward your thoughts. As I already said, severe intrusive luxation should not be misdiagnosed with avulsion. So just a quick recap. In case of intrusive luxation, the tooth is submerged, maybe mild, moderate, or severe into the socket. Here, the tooth is completely out. That has to be verified radiographically. Radiographically, in case of intrusion, either foreshortened or elongated. Here, you will not find any tooth. Treatment for intrusion, it's a major change. Any degree of intrusion in primary dentition should be allowed for spontaneous reposition. And
Technical team, she has lost the connection or not? I mean,
Yeah.
I'm not able to say.
Ma'am has lost the connection, sir. I
Okay.
think ma'am
Just we
has
will wait for 2 minutes.
Yes, sir.
Okay,
Ma'am
okay.
has to
Just
reconnect.
okay. Just wait for 2 minutes.
am I audible, sir?
Yes, ma'am, you are audible.
Yeah.
Okay, sorry, there was a. All right. So now we are done with the injury specific injuries, their treatment protocols and all. Now we will discuss a few common protocols suggested by IADT guidelines, be it any type of injury. So all these common protocols should be considered. First is the antibiotic usage. Second is tetanus consideration. Third is pain management and anxiety. Fourth, most important one is parental education and home care. Last is favorable and unfavorable outcome. Now, as far as antibiotics, the recommendation for use of systemic antibiotics. There is currently guidelines suggest no topical antibiotics for any type of injury, for any type of dentition. When we talk about and when we mention the term antibiotics, it refers to systemic antibiotics, right? So systemic antibiotic prescription in primary dentition, there is no general evidence for routine use. You may not need to prescribe in every injury, but however, there are certain criteria. If the child's medical status warrants it, if the child may be of medically compromised child, if there is any surgical intervention required, or if there is any severe soft tissue injury, lacerations present. So certain criteria, in such criteria, you can prescribe antibiotics depending on after checking for the drug allergy. Appropriate antibiotics should be prescribed. When in doubt, you can always consult the treating physician or pediatrician. For tetanus, tetanus booster may be required if environmental contamination of the injury has occurred. If you are in doubt, please refer the patient again to the medical practitioner or pediatrician within 48 hours. For pain management, luxation injuries, especially intrusion and lateral luxation, they may have, and root fractures, they may have severe pain. So analgesics such as brufen and paracetamol are recommended for managing the pain. Parental instructions for home care, again, this is one of the important aspect that IADD had dealt with in their new guideline. So this is very important for all type of injuries. So this has to be inspected. These have to be instructed. The parents and the patient, they have to be educated. So to maintain the oral hygiene, clean the affected area with soft brush or cotton swab. Good oral hygiene is essential for successful cleaning. Chlorhexidine rinse, they can be advised to use alcohol-free chlorhexidine gluconate 0.12% mouth rinse topically twice daily for 1 week to reduce plaque, debris, and the bacterial load. And they can supervise for any other potential negative outcomes. So these, when we talk about favorable and unfavorable outcome, most commonly, it may be very few outcomes may be specific for injury-specific outcomes. But overall, favorable and unfavorable outcomes. Unfavorable outcomes, we as clinicians, we should also look for it, and we should also advise the parents to look for it. For example, if the tooth becomes symptomatic, if the child has started complaining of pain or pulp necrosis, or if there is any sinus tract formation, you can always ask the parents to lift the lip and check periodically, and if they were able to find out any sinus formation or any swelling or any bulge, they can immediately report. And what are the other unfavorable outcomes? If the occlusion is not settled in spite of the best treatment that we provided, radiographic signs of necrosis, these are like the signs that we have to look for. No root development, and there was radiographic evidence of negative impact on the successor tooth. So all these are unfavorable outcomes that we may expect in the follow-ups. Now, I already mentioned when it comes to discoloration in primary tooth, we just have to understand discoloration is a common complication of luxation injuries in primary dentition. So it may fade over few weeks or months. So persistent dark discoloration may remain asymptomatic, or it may develop apical periodontitis. So when you see a discoloration, there may be a history of trauma and the child would have recovered, but not in all cases of discoloration, it is advisable to go for a root canal treatment. As long as the child is asymptomatic, no clinical signs and symptoms are visible, we may not need a root canal treatment. The child can be kept under follow-up. Now, coming to the last section, sequel of primary tooth trauma. As I already mentioned, when I say sequel, it is in both aspects. One is the sequel of trauma to the tooth itself, to the injured tooth itself in a long-term follow-up. Next is the sequel of trauma to the developing successor, which is lying very close to the injured tooth. So these two aspects have to be considered in the long-term assessment. So according to Eva Lauritsen et al. In 2017, they have done beautiful retrospective studies of to assess the risk of healing complications of different types of trauma. So in case of luxation injuries, the risk of pulp canal obliteration and pulpal necrosis are more common in case of intrusion, followed by lateral luxation. And then pulp canal obliteration is more than in subluxation and then extrusion. Similarly, pulp necrosis is more in intrusion, lateral luxation, extrusion. So it is, descending in the order of severity of the intrusion. As I already said, intrusion and avulsion are considered as most severe form of injuries in traumatic dental injuries. Now, if we talk about the risk of ankylosis, that is found to be in ankylosis in primary dentition, remember. Okay. So in case of ankylosis, the risk of ankylosis is found to be present in cases of intrusion. Now, this is another important aspect why knowing about primary tooth trauma is very important. It's all about ultimately it's going to fall on that developing permanent toothbrush, be it favorable outcome, unfavorable outcome, whatever it is. So this is very important. So this is why understanding primary tooth trauma is very, very important. So why it matters? The apex of the primary tooth root sits close, as you can see in this skull image. How closely the root of each primary tooth is located to the permanent tooth joint. So these injuries can cause tooth when there is injury to the permanent primary tooth, and if there is any damage to the permanent tooth, but these injuries can cause tooth malformation, impacted teeth, eruption disturbances. If you can see in this diagrammatic representation of intrusion, once the tooth is intruded, it is going and impinging, it is intruded into the follicular space and impinging on the developing permanent incisor, right? So the odontogenic cells, they all mix up together, they all come together and they form a complete structure in the form of odonto or any other developmental disturbance. So this is how it happens, right? So mostly this can be expected, as I already said, higher the severity of higher severe luxation injury, more the chances of impact on permanent dentition. So intrusion and avulsion, in such cases, these two types of trauma are to be taken very close care of. So this is one beautiful review article on the consequences of primary tooth trauma on developing tooth, permanent tooth. So I would strongly recommend all the PG students to go through this article. They have beautifully explained about the age at which the trauma occurs in the primary dentition and its corresponding developmental disturbance in the permanent dentition. So all of you please download this article and read. If you can see, if the age in the figure C, that is the second image, that is the size of developing permanent tooth. So correlate it with the third image, first one. If the injury had occurred at 1 year of age, then there will be look at the amount of permanent tooth involved, right? Because it's a very initial stage. Child is 1 year. The permanent tooth development is at a very initial stage. So completely damaged. It's going to be completely damaged. So if the trauma occurs at 1 year, then there will be odontoma like formation. Similarly, the corresponding second images, 3 years. If it occurs at 3 years, then you can see yellow color discoloration or hypoplastic defects in the enamel more towards the coronal region. And if the trauma occurs at 5 years of age, almost the crown portion of the tooth, permanent tooth, is almost formed, and there may not be much of developmental disturbances. So this is just the diagrammatic representation I'm explaining. So in detail, you can read this article. So with that, these are the articles and textbooks to read. Traumatic dental injuries by Jean Anderson, most important resource for dental trauma. Chapter 22, it specifically deals with trauma to primary dentition. And this book, Traumatic Dental Injuries in Children by Rebecca Staton, we have never talked, because of time constraints, we have never talked about prevention of dental trauma, which is again very, very important. But sorry, we were not able to cover it. So I would recommend you to read this book in chapter 10. They have beautifully explained how to prevent trauma according to age of the patient. So these are all the other IADT guidelines. And the third one is the article on permanent tooth consequences. So thank you for, I really thank ISPPD team for giving me this opportunity, and I enjoy being a speaker as well as a part of organizing team. And my best wishes to all the PG students. Thank you so much.
Thank you, Dr. Pavitra, for your enriching presentation. I would
Thank
like you to address some of the queries raised by the students one by one. I think the first one is okay. I don't know what about case 2. You use TAP and calcium hydroxide. Which is your case 2?
What cases TAP and calcium?
Either the question is not clear or it is.
There is one question, sir. Partial pulpotomy with calcium hydroxide will cause internal resorption. So that by Shreya Patel. That's actually a wonderful question because I was expecting this question. It was taught to the PGs that in case of primary tooth, if you do pulpotomy with calcium hydroxide, it will cause internal resorption by activating odontoclast. But when it comes to, see, in this case, you have to understand the difference between the nature of the pulp. This calcium hydroxide will cause internal resorption in cases where the pulp exposure of carious pulp exposure. Traumatic pulp exposure is different from carious pulp exposure because in case of carious pulp exposure, there is already infection, inflammation, maybe till coronal pulp or maybe extended till radicular pulp. When you place calcium hydroxide, it also causes necrosis. So there is sustained infection, inflammation, everything is there. So that keeps on activating odontoclast, resulting in internal resorption. But in case of trauma exposed pulp, it is not as contaminated as your carious exposure pulp. So you just remove the exposed traumatic pulp and remaining completely entire pulp is very healthy, and you can place calcium hydroxide and that may not cause internal resorption. So that is one of the major differences.
Ibuprofen is not indicated in children. So what are the other drugs you can prescribe?
So if ibuprofen is not indicated, we can go for paracetamol depending on the age.
Okay.
Acetaminophen or paracetamol is the safest class of drugs next to ibuprofen.
And the other question is, I think, how long we should wait for after a trauma to opt for the pulpectomy if patient is having aesthetic concern?
Sir, I forgot to mention when I was talking about discoloration, I was just talking in terms of clinician point of view. If at all, from a patient's perspective, aesthetics comes first. If the patient is more concerned about the aesthetics, then we can go for proper radiographic assessment, clinical assessment, and then we can perform a pulpectomy. It is totally patient's choice when aesthetic comes into play. We cannot defer the treatment.
Okay. Rest of the question you can answer in the chat box. Can you have a certificate, technical team? Pavitra, this is your certificate of appreciation from ISPPD office. Thank you for your lecture.
Thank you, sir. Thank you.
As we come to the end this session, that is traumatic dental injury, we will take a short break and we will restart at 1:30. Thank you all.